That's exactly right. That's exactly right. Well, welcome, ladies and gentlemen, and thank you for attending what truly is the most exciting presentation panel workshop for the day. At least this select group, as less than 10% of the attendees, as it always works out, is the smartest 10%, and will be here to learn the most for the day. My name is Jim St. Clair. I'm a Senior Director of Interoperability and Standards for HIMSS. I am thrilled to be here today with my esteemed colleagues to discuss the aspects, ins and outs, nuts and bolts, and latest developments for interoperability and standards in progressing and advancing mobile health. One minor note, Chuck Jaffe, President and CEO of HL7, was going to attend today, but my colleague Chuck, unfortunately, was called away to the World Health Organization, where they're announcing the use of HL7 for their health standards. So I will be filling in for him and giving his presentation. Excuse me. I'm also joined by my colleagues Mark Kramer from MITRE, Aaron Goldmans from West Health, Chuck Parker from Continua Alliance, and Keith Boone from GE, each one with an excellent aspect of developments around mobile health standards. With no further ado, because Mr. Parker will have to be catching a plane, I'll allow him to take the stage and discuss the Continua Health Alliance.
All right, do I have a slide presentation? Let's see. Oh, there we go. All right, so I'm just going to give you a little bit of an overview of Continua, sort of where we are, what we've been doing, and understanding a little bit why we're in existence to begin with. So it's really truly about beyond the four walls of healthcare. So it's taking a look at, and Continua's focus has been on those items that are not typically found in the acute care space. So we're outside the four walls of what you would consider the traditional healthcare environment, the hospital, and most of the acute care clinic type of an activity. So we're focused on things such as, how do you interact with the physician office, how do you interact with long-term care, and most importantly, really, how do you help an individual treat themselves at home and be able to monitor and measure themselves and effectively be able to collect that data so it can go back into the healthcare system with ease in this case. So it's really truly taking a look at how do we move to that individual. Today, that adoption rate is relatively low. We see less than 7% across the globe using these types of technologies in this setting. It is really mostly limited to post-acute recovery in the case that we're following up with somebody who typically has either had a heart attack or somebody who's had a critical condition that will want to just do some additional monitoring. We're starting to see that number grow. We're starting to see additional incentives put in place. The ACO models are certainly going to help push this type of activity. On an international global basis, we're seeing that need and drive to get people out of the hospital and from an elder care perspective, keep the individual safe and well at home longer. So we're seeing how we can actually achieve that data. Some of the other things that we're interested in too is how do we make sure that we can combine that data. Typically today we're having to monitor that individual, and there's a manual process for collecting that data and inputting it. So we want to make sure that we can integrate it with the clinical data on the back end and apply clinical rules in some cases. So we can, by collecting this data, start to look at clinical decision rules, and eventually when we begin to collect enough of this population health data so that we can begin to treat people and with new and perhaps even different types of technologies and techniques as we begin to understand how to better address their needs when they're at home in this case. So we take a look at this. Some of the other reasons here is that we're seeing the continued rise of health disease states. In this case, this was research done by PricewaterhouseCoopers. But we're seeing that hypertension is continuing to rise, and it's projected to rise on a global basis. We're seeing that as well with diabetes, heart disease, and some of these other conditions, which typically do require us to have some level of monitoring to help the individual understand their condition or their disease state. So if we can provide them with the tools, they at least get some very good feedback on what's going on with them. So what are we taking a look at here? Continua's mission here is to focus on creating an ecosystem of interoperable personal healthcare devices. And it's really to understand how we connect those devices and create that ecosystem. The word ecosystem here has a much broader definition than just the technology itself. Not only do we focus on getting the standards in place and making sure that there's guidelines for interoperability and then a certification process, but that ecosystem also incorporates working at a policy level. We want to ensure that we're doing on the policy level things that, on a regional basis to ensure that we can have the technology adopted. So that means here in the U.S. working with the federal authorities. So we do have a work group that does that. We've been very active whenever the legislation comes up for this type of activity in both the ACA as well as the original HITECH Act back about 4 years ago now. But we want to ensure that those legislative agendas also aren't restrictive in this type of an environment. So there are several states that have some generalized level of restriction in using these types of technologies at home and being able to monitor an individual. So we try to find ways to make sure that we can eliminate that barrier as well. And on the other policy, on the regulatory side, we're working very closely with organizations like the FDA. So it's understanding how do we make sure that the policy decisions allow this technology to happen as well. So, from a standards-based approach, we can certainly create all the best standards, but we need to also make sure that regulation doesn't get in the way of those standards as well in this case. So why is this important? Because if we simply have the tools, there are certain things that we can do to help modify our lifestyle. So if I simply know what the information is, if I'm a diabetic and I know what that information is, there's a good chance that I can do something about my condition, and actually I have control over it. So 91% of what we're seeing here in diabetes is controlled by ourselves if we simply have the tools to understand and help really trigger those events and eliminate some of those conditional issues that we have. So here's just some additional data about why this is actually important and why we're seeing a significant interest in this across the globe, is that there are real reasons why this is actually a value technology. And we want to make sure that we're implementing these effectively, so we want to be able to scale them. So that's why you need standards and interoperability with this capability. And now, along with the fact that we now have shown that and demonstrated that this actually does save money to the healthcare system overall, and not only save money, but it also saves lives and improve quality of life and outcomes. So, getting to the meat of what this topic is about, where are we at today with the standards, and what are we doing today from an implementation perspective? So we already have defined an architecture that allows us to go from an end-to-end state, meaning that I can start with devices, I can go to a collection hub, using what we call our WAN sender and WAN receiver, collect that data on a wide area network capability, and then on the back end, integrate that data through our health records network interface into electronic medical records, personal health records, or health information exchanges as need be today. So we're using a full set of standards in this case. So just a quick note, Continua itself is not a standards body. We don't make standards. We don't write standards in this case. What we do is we profile existing standards in the industry. So we create it and are driven by a set of use cases that then, once we've voted and understood what those use cases are and have described them well, we decompose those into components that then get worked on by our technical working groups as requirements then to go out and see in the industry where are existing standards that meet those requirements today. We don't want to go out and try to recreate the wheel. We want to make sure that we're using existing activities that are already in the marketplace. So for our device architecture, we went out and have selected the IEEE 11073 device architecture to describe devices themselves. We then combine that with a transport mechanism, and it can be one of four today, and that is either USB, Bluetooth Low Energy, or Zigbee. And then those are then, information is then, can be transported into a hub. And the hub itself can connect to one or multiple devices today. So we can, the intent here is so that you don't end up with siloed approaches. You now have the hub able to connect to a blood pressure cuff, a weight scale, a glucometer, a spirometer, a thermometer, all at the same time, and be able to collect that data effectively in one packaged solution set. On the back end of that, then the data gets transformed a little bit into an HL7 message stream at this point, so that we want to ensure that we're passing data into the health system as it can be consumed. So yeah, I work very closely with Chuck Jaffe, who's not here on this, but we, from an HL7 perspective, now transmit that data. And then we have a security wrapper that goes around that using the W3C standards for SAML 2.0. So we want to ensure that we're passing this data securely across the wire or through the air as need be. And here again, based upon the fact that we're working on an international basis, we research on a global basis what is it the requirements are going to be. So we're trying to adopt the highest level standards for what can be accomplished based upon EU directives, based upon HIPAA regulations here in the U.S., based upon federal security regulations, and those also respective to other countries that we may be operating in. But we combine all this together, and at the end of that, we actually hand off, for example, a CCD document, in this case, under the CDA architecture. In cases where we need to, we also can hand off streaming data as well, because there are going to be some times that you'll need the viewpoint of basically a timestamp of data. So in essence, I need to capture for a sleep apnea study perhaps 20 minutes of a pulse ox to understand what the oxygen saturation is during that time frame. So we do have a mechanism to allow that streaming data so that you're not flooding a repository with documents in this case as well. So just a little bit different viewpoint of this, but sort of a block diagram of what we is that we try to accomplish here today. So it's we go from the health receiver device, which is the endpoint that we're transmitting to. So if we start at the bottom, in essence, this is a device at the bottom, and work your way up. The PAN devices are the personal area networks. LAN is something that we look at from a LAN architecture. So you may ask, why do we have several transport mechanisms from the device perspective? Well, USB is wired. In some cases, we have to have a wired solution. Bluetooth is and Bluetooth Low Energy now are what we call our personal area network solutions. And then on the other end that's the LAN IF, which is what we use Zigbee for. Because Zigbee, in essence, I could put up 4 or 5 nodes in this entire building and be able to monitor you as you travel throughout the building. And it allows us to create fixed location, whole location monitoring type of solutions. This is very good for example, long-term care facilities, or perhaps even whole home monitoring, where we want to monitor an individual who's going to be somewhat just homebound and be able to, they're going to be traveling around in their house. But that's where the LAN devices architecture comes into play. As another device architecture, we'll be including NFC in the near future, so we'll actually be working with the NFC organization to allow tap-and-go structures as well, so we'll be able to capture data directly off the device just simply by an NFC chip tap-and-go type of architecture. We then, as we hear again, the device information is then collected into the AHD, and the AHD can collect devices from both LAN and from PAN in this case, and then transmit that over the WAN into the back-end systems. So this is another viewpoint, but some of the other standards and how we're actually integrating these types of technologies together, just so you know here. We work very closely with these standards bodies. So where appropriate and where needed, we actually help staff those standards bodies to get things completed. So a case and example of that is an IEEE. So we use the 11073-104XX nomenclature for the devices. Sometimes devices aren't there yet. In essence, we have a couple of companies who are working with Continua on sleep apnea, and some of those are not yet described in an IEEE architecture. So we go back and help them understand and work with the IEEE infrastructure to get those devices described, inputted, and get a nomenclature established for the IEEE architectural design diagram for that particular device. So we do help and work with going back to those standards bodies. Here again, we're not creating those standards, but we're helping organizations that are doing that create those activities as well. So that's what we're doing here in this industry here to sort of help architect how we're creating these solutions in this case. So some examples of some of the solutions. We're already seeing this already out there today, and how these are being implemented. The VA has been doing this now. It's now more than 70. Actually, that number continues to change. It's almost 80,000 now end users of the technology where they're now deploying this. That's no longer a pilot. This is the way that they're doing business. So they're actually rolling these type of technologies out on a regular basis now. We also saw this implemented relatively quickly, and these solutions allow for rapid prototyping and rapid development. When you have standards-based approaches and interoperability already defined, it doesn't take you long to implement technology. So in the Japan earthquake and tsunami, we were able to, our member companies were able to come together and within 10 days create a solution that could go into the refugee camps and begin to monitor those individuals, most of whom were over 55 and had at least one, if not multiple, health conditions in those camps. And so we actually saw and demonstrated how this technology can be rapidly deployed and prototyped in a one-to-many relationship, and be able to actually help identify health conditions and keep individuals healthy. And we actually did demonstrate a 14% improvement in the health camps where these technologies were deployed versus those that were not, did not have that same type of technology over basically a 6-month period. So this is actually a very good case point example of how this interoperability, once it's defined and once it's implemented, is easy to create solutions in emergency situations in this case. So Continua itself doesn't go this alone. We actually work with many different partner organizations. We want to make sure that we're collaborating where possible. As I said, we don't create standards, so we want to collaborate with those organizations that do here, and many of them are here on the panel. So we work with many different organizations, not only from that perspective of the standards, but also with other industry trade groups to ensure that we're getting the message out there as well. And then ultimately we also look at certification as well. So we're working with several organizations who are certification bodies for Continua in this case, to ensure that we're applying what we have achieved here in the industry to a good set of devices and architectural input, so that we can create a certification mechanism for these device architectures. So just one last slide here, and a little bit about interoperability, I think that's why you're all here, is that we know that it enables robust and convenient data exchange. It allows us to get to scale. We just simply can't do it. You can't get to scale. You can't deploy millions of devices without having some level of interoperability. It promotes positive user experiences here as well, because now I don't have to customize the solution. I don't have to create multiple ways to connect data. So if we take a look at some of the solutions that we saw on the show floor today, it requires you to have that data on the back end integrated at a high level, and you may not have a simple single portal that you can actually integrate the data and see it all in one place. And it really, truly allows us to introduce flexibility for launching and maintaining home health and other personal connected health programs. So I think one thing I've been describing to people today is that, we have companies out here, and many of them who are on the show floor, who are quite happy with surviving with thousands of deployments, meaning they can get 5,000 to 10,000 deployments. The world, though, needs tens of millions in deployments, and you're not going to have a single company that's going to be able to deliver at that level of scale anywhere in the world. So in order to be able to achieve the solutions, you're going to need to have implementations of standards and interoperability to ensure that you can actually have that overall architecture in place so that you can have a plug and play, and many companies can participate in that ecosystem at that time. So that's it for my talk. If there's any questions, feel free to ask. And like I said, unfortunately, I'm going to have to step out here in about 20, 30 minutes. Thank you.
Thank you, Chuck. And the approach was to be interactive, so we'll take questions as we go along if there's any questions immediately for Chuck, particularly in respect for his time and travel schedule. I'd add that I'm thrilled to see that everyone, or that the vibe from the room emanated a bit out so that other people were drawn in, be able to appreciate the knowledge and experience they'll be able to get from today's presentation. So welcome for new attendees that have wandered in. Our next presenter is my friend Aaron Goldmans. He's the Senior Director of Business Development and Strategy at West Health. They're actively involved in a number of initiatives surrounding interoperability and standards with mobile and wireless solutions, and I'll let Aaron spend some time explaining those to you. Thank you, Aaron.
I'll wait just a moment for my slides to come up. Oh, there they are. Actually, I think it's interesting. I don't know how many folks in the audience have been here all week, but this is actually the fourth presentation at the conference with the words both interoperability and standards in the title, and I think that's both telling and interesting from the perspective of there's a lot of activity, interest in this topic, in this space. I'm glad that we have a little bit more time this afternoon so we can kind of walk through it in a little bit more detail, and I'm looking forward to. But just show of hands, how many people have attended another presentation with interoperability in the title? So we have a core group here that is absolutely, absolutely fascinated by it. How many of you went to all the other presentations on interoperability? Okay, so, okay. So I actually did share a little bit on Monday. Some of my comments are going to be similar, but today we have a little bit more time, so I'm going to go into more depth. And as Jim said, this is, since we do have time, it's the end of the conference. Feel free to ask questions even as we go along, because let's utilize. Hopefully, you get the best out of this type of dialogue and interaction. So I welcome you to raise your hand, go up to the microphone, whatever else. I'm happy to kind of accommodate that kind of interaction. I'm actually going to pause and talk a little bit about West Health and who we are and why we care about medical device interoperability, because I think that frames a little bit of the comments and the trends and where we're going. I've showed this slide before. We've talked about it many times. I'm not going to go into it in detail, but it's interesting because my organization, which I'll talk about in just a moment, is very focused on the cost of healthcare in the U.S. The trend that we're seeing right now is close to 17-18% of GDP for healthcare. That's increasing, and as we look at the current trend and trajectory, we have so much burden of healthcare on the U.S. economy that it really creates a crisis. This is something that has been talked about. It's been theorized, it's been articulated, but we're really starting to see some of the challenges of that. We're you know, Congress and the President are talking this week about the fiscal cliff and how to deal with that. And the item that scares a lot of people is how that's going to affect health care and how we're going to pay for health care with our current budget problem. So when we think about that as applied to what are we going to do about changing that, either kind of closing the cost curve, bending the cost curve, or actually saving costs in healthcare, part of that is how can you be more efficient in the practice of medicine and care? And that involves a lot of things, but one of the things we think about is how we can look at medical device connectivity and data interoperability and a more efficient care process in general. So West Health is an independent initiative that's focusing on lowering the cost of healthcare. We actually have 4 different entities. The West Health Institute, San Diego-based medical research organization. The West Health Policy Center, which is based right here in Washington, D.C. We also have an investment fund and an incubator. All of this is through the efforts of Gary and Mary West, who are billionaire philanthropists that really want to make an impact on lowering the cost of health care. And that's what I'm going to talk to you about a little bit today. So our mission is to lower the cost of health care and really focus on patient-centered solutions. You know, that's something we talk about a lot. It's mentioned a lot in a lot of organizations' visions. But the real key here is getting the right kind of care at the right time at the right place. And in order to do that, you have to have the right data to make the appropriate clinical decisions. So I'm going to talk about 3 or 4 trends. And I mentioned these a little bit on Monday, but I'm going to have a little bit of a chance to talk to them about in a little bit more detail today. So the first thing, and all of these are kind of recent news, recent events that have happened. So the first one is the Institute of Medicine just released a publication. That publication is, the best care at lower cost. It's a lengthy document. I do think it's quite interesting and worth a read. It's publicly available, Institute of Medicine. You can find it fairly easily. They talked a lot about what their recommendations are for moving forward. And the first one, which is fairly profound, is around this digital infrastructure. It's enabling the right data to really enable care in a much more efficient way. And, the recommendation is listed there. Data generated in the course of care delivery should be digitally collected, compiled, and, protected and reliable, and et cetera, et cetera. The interesting thing is when they talk about strategies for reaching that, clearly data has to be available in an electronic form, but interoperability is a key item. Much like it's a key topic at today's this conference, interoperability is a key component to enabling not only the collection of that data, but being able to share that data. So important, timely, interesting. Another interesting recent publication comes from the ECRI, or sometimes referred to as ECRI Institute. It's a Philadelphia-based institute based on provider organizations. They do a lot of evaluation of medical technologies. Every year they report kind of a top 10 health technology hazards. Real key issues that are causing challenges in terms of how technology is delivered. This is their list for 2013. This is also a publication that you can go access. It's available, and they go into details about these top 10. Interestingly, number 5 on this list is interoperability failures with medical devices and health IT systems. It's profound. It's interesting. It's obviously a key topic. I also want to point out that if you look at the rest of the list, particularly number 1, number 2, those also have to deal with medical device interoperability. Alarm hazards oftentimes have to do with the ability to improve alarm or alarm communication. If you have interoperable systems, you can actually streamline or solve that problem effectively. The second one is medication administration errors using infusion pumps. also something that, as you look at the progression of what the industry is looking at around medical device interoperability, it has a lot of profound effects. So again, another timely, interesting, and this also brings in the topic of safety, which we think is profoundly important for medical device interoperability. The third kind of interesting topic I'm going to point out that there was a conference in, it was a summit sponsored by the AAMI and the FDA that happened here in the Washington, D.C. area in early October. This is, bringing industry groups together and talking about a summit on medical device interoperability. There's actually going to be a publication that's going to come out later this year, I believe, that's going to be available for download, and there's also going to be a print publication. This is just a quote from the press release that happened the day after, but it talks about some of the challenges that were identified in that summit around misaligned incentives and lack of standardization. I'm going to talk about standards, and clearly the topic of this session is around standards and how standards impact interoperability, and I'll come back to that, and it is something that's profoundly important, because I think we sometimes confuse also the capabilities around interoperability, which can be achieved in a very proprietary manner, versus achieving those through a standard-based approach. The kind of next aspect is, this is a kind of chart just showing all the progression of connectivity within the ecosystem. And clearly this is hospital-based all the way reaching to the home. This is courtesy of Jan Wittenberg from Philips Healthcare. But I think it's illustrative in terms of the fact that it's a very complex issue. And I also like to point out that wireless and mobile, while we often think about technologies in the home, the mobility of devices, I think, spans that entire spectrum. And we see a lot of use of applications of wireless technology entering the hospitals, entering nursing homes, entering other healthcare delivery systems. And we have to think about continuity of care and interfaces, especially across the ecosystem and with electronic health records. So this is my humor break. Bear with me because you guys can't see it. So it's it's a patient sitting in a bed. It's the latest technology, pacemaker, MP3 player. That's where you plug your earbuds in. So it's my quote here is plug and play interoperability for medical devices. When are we going to get to the place where we have plug and play? And it's actually while this is humorous, it's quite a joke. And I did come from the implantable cardiac space. I spent several years in business development at Guyton Corporation, so I know about these technologies. The interesting thing is how much we've advanced in our consumer electronics from a plug-and-play standpoint in many cases, and how far we lag behind from a medical device standpoint. There's a lot of reasons to that. But there's also a lot of opportunities that can be leveraged. When we think about the impacting medical device interoperability, we think about it in terms of these disruption drivers. And I'll talk about each one of these in a little bit more detail. So the first one is accelerating the adoption of interoperability standards. We talked, we just heard a presentation from Chuck. I think Continua is doing phenomenal things in terms of promotion of interoperability standards. I think the space that Continua has focused on, especially around the mobile healthcare space, is really moving in incredible speeds. But there's a lot of technologies that still aren't adopting those standards and protocols. And there's also a lot of opportunities, we think profound opportunities from a cost perspective, to create more interoperable devices within the healthcare delivery settings, such as hospitals and higher-end care settings. And it's important because when you look at some of the use cases around interoperability, they're around safety and creating connectivity and creating a lot of real clear value. that benefits the healthcare delivery setting in a profound way from a cost setting. Think about when the challenges of somebody taking a reading from a device and having to manually enter it into an electronic record. There's errors, there's transcription errors, there's time, there's a real quantifiable waste associated with that. The cost associated with creating proprietary interfaces, connections between those devices and the back-end system accumulates across the ecosystem, and that happens on multiple devices multiple times. Bridget Moorman did a publication under HIMSS that said it's up to $10,000 per device for a hospital system to create a connection to a proprietary device. You multiply that across the number of devices that are being integrated and the number of systems that are creating those connections. That's where you really see a cost to the system. I think it's important to pause here because we've actually done some research in this area, and I think it's important to look at the cost associated with a standard-based approach and that of creating interoperability itself. There are examples, really interesting ones, where a device has taken another device and created an interoperable system and actually taken that through the FDA. There's a great example of a CareFusion infusion pump with a pulse oximetry monitor associated with that. Great use case about pulse oximetry and infusion pumps and having a closed loop interaction in terms of monitoring. The interesting thing is what we'd want to get to is a place where those devices could be separate and have a trusted source for communication. You can create proprietary means of connecting technologies together, but the real value comes when you can create trusted open interfaces that enable that to happen in a very secure way. And I think there's a distinction there that's important to point out. So the other point here, so I'll walk through the rest of these, is proprietary high-cost data networks. This is where you still maintain, and as a device manufacturer, you're somewhat incentivized to create a closed-loop system, including your back end. And there's many systems that hospitals then need to integrate together to create their interoperable ecosystem. That creates data in independent, disparate silos. There's a huge opportunity to advance that forward if that data doesn't exist in silos and doesn't exist independently. That's a real challenge as we move forward, because I think the incentives are still there to create data and to maintain it in a siloed setting. The other area that we think is really interesting is the barriers to innovation. And I've also worked for a startup company, a company called CardioNet, which is now a public company. But when you look at young companies that are developing very innovative technologies, the incentive to take the extra work and the extra effort to go down a standards path versus just creating the kind of the easy path of whatever your engineers can do to get it done, I think is a challenge. And as a young company, you don't want to go take that extra engineering effort when you look at standards as they often exist today, where there's stacks of codes and requirements, and to implement those. So as a young company, I think there's barriers. So I think it's important, and Continue has actually done a lot in this space, especially in the mobile ecosystem, to make it easier, to make it accessible to implement those standards in a clear and consistent way. The last one is more about how do we enable care delivery in a much more effective way. So this is much about the vision that I outlaid at the beginning of my talk in terms of the right care at the right time at the right place. Some of it, just like when the iPhone came out as a new technology platform, people didn't know what you could do with all the applications that you could create on top of it. It became a platform, Android as well, for the creation and the innovation around care pathways, pathways for creating applications and uses that you couldn't imagine initially. I think when we think about an interoperable system, part of it is about the care pathways and the efficiencies that we don't even envision that can happen today, but will be a result of being able to access information at the right time at the right place. And this is also spurred by a lot of changes and potential changes in how we look at reimbursement and how our care delivery system is incentivized. But when you move towards accountable care organizations or capitated payment models, you enable healthcare delivery to look at managing patients in a much different way. Access to the right information at the right time really enables that to happen. All right, so this is just a short list. I included both Continua, HL7 on the panel. Amy and UL announced a collaboration around standards, integrating the healthcare enterprise, is also here, and has done a tremendous amount about defining standards. As Chuck said, Continua and IHE are not standards organizations, although I understand IHE is a standards organization now. The bottom line is, and I think it's important to appreciate, there are standards today, and there's standards guidelines organizations. There's a lot out there. The problem is they're not implemented consistently and broadly, and that's a problem. And I think we have all these panels around. And discussions around interoperability and standards and where are they and when are they going to happen and all the standards we need to create. At some point in time, I think it's very important for us to stop and sit back and say, look, we have standards. Yes, there's gaps, holes, there's opportunities for improvement, there's opportunities for advancement, but the real problem is that they're not being implemented and they're not being utilized, and there's opportunities there. And we're very eager as we kind of step into this somewhat as a new organization to this space to the phenomenal work that's been done for many years by many dedicated people to really try to tackle this issue and try to define it. So I think the opportunity is to help advance it, help move it forward, and help make it possible to realize the benefits. I actually stole this from Mark Prost, the CIO of Intermountain Healthcare. The reason he gave this example at a recent congressional hearing. The interesting thing is I love the visual. I love the visual because, and let me just explain what this is. This is the railroad in Australia. When they built railroads in Australia, they did not think about it proactively and create the same gauge of track. And there's now 3 different track gauges or separations between the rails. And this is something that they've been dealing with for 100 years because, as you know, it's expensive to lay track. It's really expensive to rip it out. So the visual here is actually a rail transfer cart where you actually have a very sophisticated, expensive system for switching, picking up a car one at a time and switching the wheels so then you can keep the train moving forward. The point and why this, I think, visual is so powerful is it's important for us to be proactive and think about interoperability from an industry and from the warning of the implications of cost. Because if we charge forward in a bunch of different proprietary ways or a bunch of different standards ways, we will end up costing the system and each one of our organizations a lot of money to create these Band-Aids and temporary fixes. This is very easy to see, but you can envision the same thing from interoperable medical devices. Quite frankly, some of that exists today. There's patchwork, there's translators, and it's often not done in a very effective way from the standpoint of sometimes those translators or patches are written by some IT staff in a hospital, and we're talking about creating data exchange between hospitals through electronic healthcare exchanges and so forth. So you need to think through how to do it and how to do it right the first time. So I love the visual, and I think it implies a lot of the cost challenges that we have if we don't do it right. Now let me just talk a little bit about a vision that West has. Some of our engineers in San Diego are actually working on this, and we're working collaboratively with industry. So again, this is somewhat of a wireless hospital-based approach, but I think it applies across the ecosystem. We think that there's an embedded software opportunity to take a lot of the work of the standards organizations and make it very compact and condensed and make it available to the healthcare delivery ecosystem, especially the development ecosystem, by creating interoperable software, standard-based, that incorporates the standards in a very meaningful way to make those widely accessible within those devices to make standards easier to adopt. So not creating new unique approaches, but trying to apply the standards-based approaches and making those available in the ecosystem. So why is that important is if you can make that available at the lowest layer of the development ecosystem, the operating system, or even the silicon, the chipsets, you can create the application of those standards that they're easier to implement in the development ecosystem. This helps both large manufacturers as well as those startup companies I mentioned before, because then when they're making their choice about developing something, if it's so accessible and there already, then that makes it very easy for them to implement and adopt. There's many examples of this, but a great example of this is how we think about network protocols. So TCP/IP is well embedded within the development ecosystem. When you go, buy a silicon chip today and you want to implement internet protocol, a lot of that software for that to happen is already available, and it's very easy through creating the right plugs and the right APIs to connect that. So that's the approach we're taking. We think it's reasonable, and we're working with the ecosystem, including IHE, to try to prototype and demonstrate this capability. And in fact, we're going to talk. We're at HIMSS in 2013. The next HIMSS large meeting in New Orleans, we're going to have a demonstration of this capability with some ecosystem partners to talk about that possibility through the interoperability showcase for the IHE innovations. Then, yeah.
Can you jump back one slide for a second? I'm Chris Brancato from Deloitte. I'm a little confused by the paragraph that you have leading into that. Developing software to simplify the adoption. Do you mean adoption as an implementation? Or help me understand what
So is the word you're struggling with adoption?
Adoption.
Yeah, so...
adoption to me means an industry uptake
yeah.
of a standard, not the implementation of a consistent application of the standard to industry.
Yeah, so we can argue about the words adoption or implementation. The bottom line is more devices than not aren't transmitting data in a standardized way. Well, so it's adoption of the standards, it's implementation of the standards, it's actually embedding the standard-based way protocol of transmitting data. We're very much interested in the at a fundamental device level, the IEEE 11073 standard, which is consistent with Continua. They're both on the PhD, which is personal health device, which is very much the mobile space, but also POC or point of care, which is the in-hospital side of that. And we're working also on looking at progression of that standard, and we're working within the IHE standards organization to help drive that forward.
I apologize for the semantics. I just want to make sure I understood what you were trying to.
Semantics are very important, as we know.
Especially when you're an informatics guy, it is.
On semantic-based interoperability, ultimately. But I agree with your point, Chris, and I would offer part of the debate, the discussion is around what does adoption of standards mean and how they are adopted. In this case, in this approach, adoption begins literally with implementation. So especially if you consider this from a mobile device standpoint, and moreover what that means to mobile health, and the degree to which the line is blurring between a traditional FDA-regulated mobile or a medical device and something that's brought to you on your iPad, by embedding, so to speak, implementation of the standards at the firmware level, it alleviates the sorts of challenges associated with adoption and more of the cultural change technology aspect at what level of an organization fosters it, promotes it, etc.
Absolutely concur.
Thank you. Great question. Thank you.
Anything else? This is actually my last slide, but I just want to pause here for a second because I think it's fairly fundamental to think through how do we achieve interoperability. I think this is more at the industry level and how we think about promotion of the implementation and adoption of interoperability. But it is a balanced approach, or will require a balanced approach. I think, from a technology standpoint, what I just described and what the Institute's working on in terms of interoperability software, and quite frankly, a lot of what Continua is doing and a lot of what a lot of other folks are doing within the standard community is really what are the standards and how to adopt them from a technology standpoint and enabling that adoption, and really making it easier and accessible to adopt those standards. But there's a couple of other really critical pieces, and actually some of my colleagues and I share a lot of working activity around policy and regulatory. I chair a value proposition work group for the Medical Device Interoperability Coordinating Council, which involves the FDA and tries to think through how we can drive, what is the clear regulatory path, and what are making sure that the industry understands the pathway for interoperability. It's important as we think about. I have ONC on there as well. Meaningful use, stage 3 meaningful use has just come out. It's under review. There's an opportunity for medical device interoperability to be part of that. There's very little around medical device. There is virtually no medical device interoperability in stage 2. So that's an interesting opportunity for us to think through where that fits in. NIST is working on it. We've collaborated a lot with NIST in terms of what they've done, both with HL7 and with IHE, and so there's opportunities there. The FCC, as we get into wireless and different protocols, they're an important organization as well. So the regulatory pathway, and how I think about it is the regulatory pathway can either be a huge barrier and create a lot of roadblocks on one hand, or they can create a huge incentive and push on the other hand. So I think at the minimum we want to make sure that it's not a barrier. I'll let Chuck go. Thank you, Chuck. At a very minimum, we don't want regulation to be a barrier. At a positive end, we want to make them or work with regulation and policy to make sure there's clarity and understanding so companies have a clear path forward, especially as they're working on complex interoperability. And at a far end, if there's these benefits that are really realized, as I described before, then there's a huge opportunity for regulatory policy to actually help enable and push forward interoperability. The last piece I want to talk about, which I think is very important, is healthcare delivery. As I've started to, and we've started to explore the real value proposition of medical device interoperability, one of the things that we've very much realized is there's a lot of stakeholders and there's a lot of benefits both to manufacturers, regulators, and healthcare delivery. What's interesting is the organizations that probably have the most to benefit are healthcare delivery organizations. The challenges with safety, the cost associated with maintaining multiple different data flows, and the opportunity for creating more efficient work paths that we can create with the right data at the right time. They're the most to benefit, yet they don't necessarily have the right voice or common voice to really drive the requirements. And they're not telling manufacturers in a clear and consistent way that we want interoperability or something that's important to us, or that we'll buy devices that are interoperable. That's a huge opportunity. We're working closely with healthcare delivery, and I think that there's an opportunity to even advance that. And I think it's a very important leg, because I think as healthcare delivery realizes and understands the power of the data that they can accumulate with interoperable devices, I think they'll be much more inclined to say, hey, this is something important and that we want to drive it forward. I'll pause there. I'll conclude there. If there's any questions or comments, I'd be happy to take them, and if not, we'll move on to the next presenter. Okay, thank you.
One comment. I'm from the semantic interoperability side, so a lot of this is probably one thing I observed in semantic interoperability is that one of the great things is that, if you want a standard for something, you can go out and get a standards organization to sponsor you, and you can establish a standard. And so when you put up that a lack of common standards, it's not that there's lack of standards, there's a lack of, there can be 5 different standards for a certain aspect of something. And it's needing the standards development organizations to coordinate what they are doing and what they are approaching. And if you look at the business model of some of the standards organizations, their business model is to create another standard. And they don't care whether there's a rival standard out there. So I think there's a little bit of a sociological problem there as well, that we all have to deal with, unfortunately.
Yeah, I think it's an incredibly valid point. I think I would, that third leg of my stool in terms of healthcare delivery, the users of that information, I think, have a real opportunity to come together and say, help define those requirements and the uses. And there's probably another piece to this that we've thought through a lot, that is the testing and certification of the implementation of those models. And that becomes, I think, critically important as you start to define which standards you use and how you use them and implement them, and make sure that they're utilized in a consistent way. I couldn't agree with you more. I think a lot of the standards organizations are volunteer organizations, and they don't often, I think Continue is one example where they actually have a certification process. I think that that's important. I think that there's other opportunities to create that, especially in the inpatient setting for hospitals. So when they're implementing these, they know that they're getting the right thing. I think that's a huge opportunity. Anything else? Thank you.
Thank you, Aaron. And now it's my pleasure to introduce my colleague also in IHE, Mr. Keith Boone, Solutions Architect for GE Healthcare. Standards guru, actively involved in a number of standards for years, and also a proud member of the Walking Gallery. If you aren't familiar with the Walking Gallery and what Ms. Regina Bradley has done, Keith's an excellent example, and I encourage all of you. Holloway, I'm sorry, Holloway. Sorry, I have a personal friend named Bradley, so it confuses me sometimes. Regina Holiday does, and it's available on the web, and she also tweets as well. Keith, I hand it over to you, my friend.
So one of the first rules is to make sure that the mic is turned on. Can you hear me? So the second rule is don't get disconnected from your audience. And since we have such a small audience, I don't want to be back up there behind the podium. I'm going to do a little bit of reorganization here of the audio. There we go. So I'm a standards geek for GE Healthcare, and we'll get the deck up there. That's actually what it says on my business card, standards geek. My day job is to represent GE Healthcare. I'm on the board at HL7, so I represent GE to HL7, and I also participate in a number of work groups there. I'm co-chair in integrating the healthcare enterprise. One of the reasons that I'm actually here this week is not because I plan to attend this summit, although Jim did rope me in for this presentation, but because IHE was meeting up in Reston Monday and yesterday and this morning to figure out what we were going to do for the next year in terms of standards. I'm also a member, along with a number of other colleagues in GE Healthcare, of Continua. I've been involved with ASTM. I've been involved with the ONC S&I framework activities around doing some convening and developing standards. Still waiting for my slides here. And so I've been very involved in the development. Okay. What's that? You don't have my slides on the server. Okay. All right. So my role in GE is to, represent GE to these standards organizations. It's to take this information and present it out and promote its use in industry. Because frankly, from our perspective, we have no need to do the same thing twice differently. We'd want to do it once. We want to do it the same way. And oh, by the way, when our product goes into a hospital, we're going to have to talk to a Siemens system, and we're going to have to talk to an Epic system, and we're going to have to talk to a Meditech system, and we're going to have to talk to a Philips system and some other system. Because as Chuck said earlier, although I forgot he departed, no one vendor can do it all. So we're going to have to talk to all of these different systems. Yes, we'd love to be the proprietary, we've got all of your data, and you have to come back to us. But that really doesn't have value, because if everybody does that, everybody is locked in, and nobody can grow into that market by providing better value and better service. We're not in the business of providing standardized interfaces between medical devices. No, we're in the business of making really good medical devices that do things better than anybody else's. So we don't want to worry about all of the details. So we focus on the standards. Now, when we talk about, and what I'm going to talk about is trends in mobile health standards. So we're going to get a little bit interactive here and find out what does it mean to be mHealth? What does mHealth mean? So we have an answer in the audience here. Can anybody tell me what mHealth means? Come on. You're here at the mHealth Summit. You haven't attended a single presentation that told you what mHealth was? You got an idea?
So the generally accepted terminology is mobile health.
Okay. So what
but there's so many out there. It's actually, I come from Orange, by the way, so a mobile company. And we don't believe in the term mHealth. We call it a fuzzy concept. It's definitely very fuzzy around the edges. It means many things to many people. But one way of looking at it is basically it's e-health, but it's portable. It's got mobility built in. But I guarantee you that everybody in this room has a slightly different answer.
Okay, so I forgot to bring my little gold stars and my badges. You would get one. So the key thing, oh man, you're in trouble. You got an answer?
Yeah, I do. I mean,
Go ahead, give me your answer.
you know my background, physician/engineer, so I look at it. Well, mHealth is anything that's not delivered in a standard care environment. So it's outside a physician's office, it's outside a hospital. Now there's mobility within those environments, but I don't believe that's. I think the exhibit hall is the perfect example of personification of my definition.
Okay.
Is bringing new care environments to a traditional care environment.
So this is another good definition, and you get at least a silver scar. At least a silver scar, Chris. Platinum, that's right. I have to give Chris grief because I've worked with Chris for years in the standard space, and he knows his stuff. So I have an app on my phone that allows me to get information about medications, right? And I have an app on my iPad. If you give me a second to bring it up here. I have a bunch of apps on my iPad, and this one has got all my blood pressure data in it. And I have another app on my iPad that's got all of my weight data in it. This week I'm carrying around a Fitbit. I'm actually testing this out for a corporate wellness program, right? So I definitely got my 12,000 steps in on Monday when I showed up here, rather than going to some IHE training that I could do just about any time to see what was going on here, and I got in, good 12,000 steps in the hall. Now, my definition of mHealth, and after looking at the hall, was that it's connected delivery of health care without wired connections, right? It's got the mobile, and it's connected delivery. Now, is everything that I just showed you mHealth? No, none of it is, and you know why? Because it's not connected. This Fitbit, I can get that data. I actually have to pay them to get my own data back. Doesn't that suck? Okay. But I could get that data, and I could download it into a spreadsheet, and I could actually hack a couple of the apps on my iPad, and I could pull that data out into a spreadsheet. I'm a geek, right? I could do this hackery. But it's not automatically there. It's not connected because the standards are still evolving, just like the market for this mHealth space is still evolving. So while we like to think that all this app environment and everything else is mobile health, what it's actually missing is what mHealth is missing, and what mobile is missing is the connections. So we need to get into some of the standards, and we need to get into implementing some of the standards that are being done. Now, how many of you folks here are really passionate about the work that you do in this space? I would say just about everybody's going to raise their hand. So, and the reason you're probably passionate is because you think that what you're going to do is going to change the world, or it's going to make something better for a family member. Right? You've all probably got great stories. So now I'm going to break another rule of speaking, and I'm going to turn my back to the audience. Okay? And so this is Phoenix Rising, is the name of the piece of art here. And this is a jacket that was done for me by Regina Holliday. I'm here not just as a standards geek for GE Healthcare. I'm here as a patient. I use this stuff. I want this stuff to work together. I want it to work for me. I want it to work for my mother, who, I have to explain to her how to hook up her printer to her computer still, even though we finally reached plug and play. And for my daughter, who grew up being able to hook up printers to computers before she could, and hook up connectors to gaming systems before my wife has still yet to learn how to do this. Okay, she could type her name before she could write it. So I want us all to be able to do this stuff. So in terms of what's going on, there's a lot of interesting stuff happening. And I'm going to talk to you a little bit about what's happening in HL7 and in integrating the healthcare enterprise and in the ONC S&I framework. And now that we have the deck up, so Health Level 7 is a health IT standards organization, right? So it's an organization it was primarily hospital focused when it started more than 20 years ago. And then it moved into the ambulatory space and the medical device space and other spaces. And they are doing a number of things that are pertinent to mobile health today and in the future. One of the things that they did over the last year was they created the Mobile Health Work Group. So this is a new work group in HL7 focused on mobile health. And they're still trying to figure out what that means, just like everybody else is. I think probably the first thing that they'll do is the first thing every standards organization does is come up with a definition for what it is, right? We have something else called Fast Healthcare Interoperability Resources. We have the standards that have been selected for meaningful use in the U.S. called the Consolidated CDA. That actually came out of a collaborative effort with HL7, with IHE, and with the predecessor to the ONC S&I framework projects, what was back then called the ANSI Health Information Technology Standards Panel, or HITSP, and you might be familiar with the HITSP C32. One of the reasons this jacket talks about being up until 3 in the morning is when I wrote edition 1 of the HITSP C32, I was up for 30 hours straight. Okay, so even though I get paid to be a standards geek, nobody pays you to stay up 30 hours writing documents to get this stuff out, to make this stuff work. We have Blue Button. How many people are familiar with Blue Button? Okay, yeah, just about everybody in the room is familiar with the Blue Button. You know what it is, right? It's a download of an ASCII text file, right? That's interoperable, sure. Actually, I would not wear the pin until June 4th, because on June 4th at the Patient Access Summit at the White House, which I got to bring my 14-year-old daughter to, that was the coolest thing, was for her to go to, not across the street from the White House, but a White House-sponsored meeting where she got to meet Todd Park and Farzad and all the rest. She now calls them by their first names, right? They decided that Blue Button was about getting access to standards-based data using consolidated CDA. And then our friends at MITRE have done some work on something called H-data in HL7 and in OMG. So it started off as an HL7 activity, and then they shifted it over to OMG through a collaboration effort that's going on between HL7 and OMG, and has been for some while. One of the querents here talked about one of the issues that what we have right now is that we need more coordination amongst the standards organizations. I absolutely agree with you. I wish we would have a national office that would coordinate that somehow. Okay, you get the joke, right. So I give ONC a lot of grief. They've actually done some really good stuff. And the idea that we're going to be able to download our data in the same format as a patient, I get the same data, the same density of data that my provider has, and now I could plug that into an app. And that app could keep track of my meds, and it could make a nice list of meds, and then I could go to Medline Plus and find out what the possible side effects are for that med, or I could say, yes, I took my blood pressure medication today. You know, that is truly awesome. What did I do with that silly thing? Why did I do that? Okay, so the Mobile Health Work Group was put together in the last year to basically do standardization work around mobile health. And their two focuses are, what data standards do we need to enable mobile health? And what are the functional requirements that a mobile health app needs to have? Or a mobile health device. What's the functional requirements for something like this? Or perhaps a patch that can monitor a patient's cardiac signs, right? Or something else. To identify and promote those concepts for interoperability, to cooperate and coordinate with other groups interested in using mobile health. Basically to become a forum where we can get all of the stakeholders in the room and talking to each other and sharing information. I was at one of the 4 standards and interoperability presentations earlier this week, and I heard somebody talk about, the new lovely architecture framework that they were developing. And the first question I had is, so do you consider yourselves a standards organization? If not, what relationship do you have with them? And the answer I got was really disappointing, because the answer I got was yes. Oh boy, I need another standards organization like I need another hole in the head. Well, actually I went back, and it turns out that they are aware of some of what's going on, and they become aware of what's going on because of this mobile health work group in HL7. One of the things that I'd recommend that you do is, if you're interested in this space, go to the HL7 website, hl7.org. Go to the, on the middle right-hand side of the page, you'll see a list of resources. One of them will be listservs or mailing lists. Click on that. You do not have to be a member to sign up to any HL7 mailing lists. 2 mailing lists that might be of interest to you. One of them is the Mobile Health Work Group, and the other one is going to be the mailing list for this next topic, which is Fast Healthcare Interoperability Resources. So this is a new HL7 standards effort. This is a multi-year project to develop a new version of HL7, and we are not calling it version 4. Okay, and that's for a reason. We're taking a completely different approach. We're looking at what people have been learning from the web, what people have been learning in the mobile space, in the RESTful space, and what we've learned from HL7 v3, both the good and the bad, and trying to develop a set of standards that's going to cover 80% of what we need for interoperability, because it's that last 20% that takes all that huge amount of effort. And you know what? If I can knock out 80% of your problem, I've just improved your efficiency by 500%. So let's work on that 80%. Deal with the typical data elements. I want to track my weight. I want to track the number of miles that I walked. I want to track my blood pressure, my vital signs. I want to keep track of my medications. I don't have to deal with every last tricky nuance right now. Let's get something working. Let's do it quickly. And be able to pull these atoms together to support richer and more complicated sorts of activities. Now, this becomes very interesting because this is an activity that's going on in HL7. And what you're going to see through this presentation is that different pieces of different activities from a number of different standards organizations that I'm actually working in are coming together in this particular space. This is an especially important piece. What is an interoperability resource? Well, this is the definition from the FHIR specification, spelled F-H-I-R, pronounced FHIR. And if you want to get to that specification, it's at hl7.org/FHIR. And it's free. One of the things HL7 did last year, the board did, was we voted that we were going to make HL7 standards free. And you'll be hearing more about that in March. But when FHIR was created, we decided immediately that was going to be something that was going to be free even before we decided to make all of the HL7 standards free. So the units that we're working with are granular. They're independent. You can work with that unit without being too concerned about how it's connected to the other parts. But you can connect it to other parts. They're simple to understand. I think you were talking earlier, Aaron, about who is going to implement that connection. It's going to be probably the junior level engineer at the hospital, right? So you've got to target that audience for how easy is it to understand and implement without immense amounts of tooling or infrastructure, and so that the clinical intelligence is built in. If you follow the rules, you'll get the right information into the resource. RESTful, because we found that makes things easy for developers to write code, and they can write code fast, and they can prototype and put together proof of concept, and they can do some really cool, innovative stuff. 90% of what you've seen downstairs, somewhere along the lines, is doing a very simple HTTP GET or an HTTP put or post. Why? Because I can write that in 3 lines of Java. And in some other languages, all I need is a command line. I can use curl to do some of these calls. It's extraordinarily flexible. So I can use this for messages, I can use this for documents, I can use this for full-on service-oriented architectures with all of the 3-letter acronym soup stuff that you want to put in it if you want. I can extend it, and the ability to extend it is built in. This is a very well-defined, this is how you extend this, built into FHIR. It uses the internet standards. It's using HTTP. It's using HTTPS. If you want to do authentication, you could use OAuth with this, and it would just work. And as I said, this is free for anybody to use. And it's free now. You don't have to wait. Other HL7 projects that are going on. Consolidated CDA. Consolidated CDA is the standard for stage 2 of meaningful use. Every provider is going to have to be able to support patients being able to view, download, yes, download. I want to be able to download my data in a CDA and transmit their data. And it's going to be in the consolidated CDA. So it's the standard for meaningful use in the US. It builds on the CCD, which was the standard in meaningful use stage 1. And it supports a number of different document types for general practice and specialty. So if you're a radiologist, there's an imaging report in there for you. If you're a surgeon, there's an operative note in that list of documents. If you're a physical therapist, there's a progress note that you could use for your patients. So you could actually pick the right kind of clinical content that you'd like to exchange instead of a one-size-fits-all clinical summary, which is what the CCD was. Right? We know that we can't do one-size-fits-all medicine. For those organizations that still need that blue button text capability, maybe because they've been told by CMS, they're a federal contractor, and they have to implement Blue Button for all the federal employees that they're providing payment services for. Well, HL7 developed a style sheet, this is web technology, that turns the XML in the CDA into Blue Button plain text. It's just a plain text rendering. It's sort of like if you took a web page and you printed it to an ASCII text printer, the kind of output that you would get. So it supports CCD and the CDA consolidation guide. We don't necessarily consider this to be great interoperability, but it is something that payers who have to do business with the federal government need. So we developed that. And then there's the HData work, and there will be a presentation. I think the gentleman from MITRE here is going to be talking about HData. So I won't steal his thunder. but it's mostly about record formats and transport for health data. And then we have integrating the healthcare enterprise. So I co-chair the Patient Care Planning Committee, and I've been a long-time member of the IT infrastructure work group in IHE. And they've been working on a number of different activities. They've got some old stuff and some new stuff, and some stuff that just came out and some stuff that's going to be coming out next year. And it's all up here. So mobile access to health documents came out last year. We're going to be demonstrating this in some way, I believe, at HIMSS. We're going to be hacking on it at Connectathon. So Connectathon is where we do that formalized testing in IHE, just like Chuck was talking about they do in Continua. And actually, IHE now just recently announced in the U.S. they're going to be doing certification for vendors who want to certify themselves to the IHE profiles, and there's like 3 levels of certification. I've implemented the profile correctly. I've implemented the profile correctly along with other profiles according to this, for example, HIE's set of requirements. And then finally, now it's actually implemented correctly at this site here. So 3 different levels. Anyway, we're going to be doing a hackathon. We're going to be playing with FHIR at that. So mobile access to health documents. Yes, we are going to be playing with FHIR. Okay. And I mean FHIR as in the Fast Health Interoperability Resources. Now, FHIR and the mobile access to health documents were designed to work with something called cross-enterprise document sharing. How many people here are familiar with the NWHIN exchange or the NewHIN exchange or the NWIN exchange or however you want to pronounce that acronym? We've got one up here, a couple in the back there. So this was George Bush's health internet before we ran into Obama's health internet and direct. Okay, so this was the HITSP way of doing things. And that's actually built on top of cross-enterprise document sharing. How many people here are familiar with HealthyWay? That's the new name for NewHIN. It's the new, I'm sorry, that's the new name, right? And then we have cross-community access. Consolidated CDA harmonization. So consolidated CDA came from the HL7 CCD, the HITS PC32, and the IHE PCC technical framework. Well, okay, so they came out with a bunch of new templates, and now one of my jobs in IHE is to bring all of that stuff back and make it work. And the interesting thing about consolidated CDA, well, that's for the U.S. We're going to use RX norm for meds. We're going to use LOINC for labs. We're going to use SNOMED CT for problems. We're stuck like everybody else on having a standard for allergies, and eventually someday we'll fix that. And we're going to use CPT or SNOMED for procedures. Great, move that to France. They're not going to use LOINC. They'll probably use SNOMED. RX norm, I'm sorry, that's a U.S. standard. We have this other stuff that we have to use in Europe for medications. And so we've got to factor out the U.S.-specific pieces from consolidated CDA to figure out and make that the IHE USA realm extensions to the PCC technical framework, but leave the other stuff that's good that we can use internationally, so that France can come along and say, well, you have to use this set of codes for your lab results. And we do that in a way that makes it easy for a vendor or an implementer to say, okay, well, I'm going to change this little piece of configuration here, and now my system will work with that different set of codes, as opposed to having to hard code a lot of this in. This year, so last year IHE did mobile access to health documents. This year we have to put authentication in, right? So we actually had to break that project up into 2 pieces. The first piece was, how do we enable patients to get access? And the second piece was, well, how do we secure it? We knew we needed to secure it, but trying to do that all at once was a little bit too challenging, especially since OAuth wasn't available. The OAuth 2.0 specification wasn't available yet as a standard from the IETF last year until just recently. And then we have a final thing, which is pull style notifications, right? Your device isn't always on receiving information every last instant, especially if it's cell phone. Isn't that a battery waster? Don't we just love stuff that goes down and pulls our email and sucks our battery dry? So we want the ability to when my device is on, I can go actually out and when I open up the app, go out and pull the new information that I need and get that on demand. Oops. So the mobile access to health documents, basically you've got two different pathways here. You've got a pathway where the mobile device can ask for, well, what documents are available, and give me that document. And then you also have a pathway where the mobile device can create a document and push it out to somebody. This is all done in a RESTful fashion. It can be used standalone, or it can be used with other IHE profiles. And this supports a very simplified access, again, that 80-20 rule, 80% of what we need, to be able to query and access and store documents. It works very well. We've taken the mobile health document components here and here and shown how they can hook up to an HIE infrastructure using the IHE cross-enterprise document sharing profile. So this allows us to support query, it allows us to support point-to-point exchange, and it allows us to support health information exchange and federated exchange as we're currently doing with HealthyWay. The Consolidated CDA Harmonization Project, I can say now it's not just slated or being proposed. It was approved this morning at approximately 10:30. Okay, so you get the latest breaking news about what's going on IHE by coming here. This is going to do the harmonization and the internationalization of consolidated CDA. And one of the things that I'm going to be doing is actually proposing that we take that content back to HL7 and ballot that as an international specification. Because HL7 and IHE have already agreed they're going to ballot some IHE profiles through the HL7 process. And I think that would be a golden opportunity to take something that HL7 has done, do some work to internationalize it in IHE, and then bring it back through the HL7 ballot process to gain even further adoption and acceptance of that. The OAuth option for mobile health documents is going to take advantage, we hope, of OAuth 2.0 and enable patients to be able to, do that download and authorize the applications that are actually going to do the download on their behalf using OAuth. OAuth's been adopted now as an IETF standard. But what we need, because OAuth is not a full-blown standard so much as it is a framework for creating a standard, is we need to adapt that for healthcare. And we have some very specific requirements, such as things about ticket names and the various options that are in that standard. So IHE, although we call ourselves a standards organization, operate very much like Continuum. We work with the existing standards. We are a standards organization in that we create specifications and follow all of the practices that other voluntary consensus standards organizations do. And it's easier to just say, yes, we're an SDO, than try to explain, well, we're not an SDO, but we're very, almost like an SDO. So that's why there's that sort of distinction about yes or no about SDO. There are a number of assumptions that we've looked at for this OAuth capability. One is that providers need not affiliate with one authorizing agent. So just like today, you can go in with your app and you can log in with Twitter, or you could log in with Facebook. You could have a number of different authorizers that you work with as a provider, so you're not required to use just one. And the provider need not even select one. They may be able to organize themselves and situate their application in such a way that the patient can pick which they want to use. So you could support multiples. Okay, I'm going to skip over some of the rest of the details here. The basic way that OAuth works, you have an authorization server and you have a service provider. So this is your patient portal that's going to do view, download, and transmit, let's say. And your authorization server, that could be some sort of identity provider up in the cloud. And your client could be your personal health record or a web application that you use, or an application that if you're a geek like me, you wrote yourself. And it could now go out to the authorization server and say, hey, I'm application number 97, and I would like access to Keith Boone's information. Oh, good. Well, application 97, I'm going to send you to the site that Keith Boone has selected, and I'm going to let Keith log in. So you need to show Keith the page that I'm about to give back to you. And I would then see the page, and I would see the banner, and I would see everything the way I expect it. And I would type in my username and password. And there would be some negotiation, some back and forth there. And then the information would get back to my application. My application would say, ah, great. Now I have a ticket. I'm going to take this ticket and go to the authorization server and say, okay, authorization server, I got the ticket. Can you give me the key now? And the authorization server says, okay, I'll give you the key. And then the client can go to the service provider and says, I have a key. I would like access to Keith Boone's data. Here's the key. And the service provider can look at that key and say, yep, that's a valid key. You can have access to the data because you've already gone through this whole process. And the reason for exchanging the ticket for a key has to do with security protocols. Okay, and I don't claim to understand it well enough to explain it, but I understand it well enough to know that it's necessary. The pull style notifications, I think I explained that already. We have the capability today to push notifications down. Want to drain your phone? Want to keep your phone battery from draining? Turn off push notifications. Do all of your emails on manual download, because a push notification requires always on, right? Or requires your mobile device to wake up periodically and go say, "Got anything for me?" Right, so we want to be able to do that in a pull fashion. And then we get into some standards activity that's not standards activity, but it is standards activity. So this is the ONC S&I framework. And if you've been paying attention to a lot of what's been discussed around the standards and interoperability, you might have heard some of the phrases about the government being an inpatient convener of standards. And if you've been watching the S&I framework roll out project after project out of project, it averages about one every 2 months. You get the idea what's going on with inpatient. But some of the activity that they've been doing is one of these was REX, Restful Health Exchange. And the idea behind REX, there were actually 2 phases, and they've completed the first phase, and I don't know that the second phase ever really got going. But the idea was to explore the use of something called OpenID Connect to secure access to data, for patients to be able to authorize applications to access their data. Now, OpenID Connect is based on OAuth 2.0. So there were some folks who were actually hired to figure out what some of the specification needed to look like. There was a project started to figure out how this could actually work. There was a pilot that was done to see how that would work. And they based their work on the HL7H data record format and the OMG H data transport. Oh, I forgot to tell you, FHIR is also doing the same thing with H data. And then we have the Automate the Blue Button initiative. So there was a patient access summit convened by the White House, and it was held in a meeting room about half this size in a building right across the street from the White House. I was going to be there that day, and I had gotten an invitation. And I had my 14-year-old daughter was also going to be with me because she was getting a jacket from Regina Holiday as well. So I got to bring my daughter to this meeting. It was a blast. Now I've got to figure out what I got to do for my 10-year-old in a few years, because I've already gotten my daughter invited to a White House meeting, right? The Automate Blue Button initiative came out of that activity. If you've seen these little blue buttons on people with the looks like a little tray and a down arrow, you know, that's the icon for Blue Button. There are 3 work groups. The content work group has actually finished their activities, and what they said was, well, we're going to support the use of consolidated CDA so that every use of the ABI protocol can count for a view, download, or transmit for a provider. So when the patient goes in and they use the protocol that the ABI project, oh, did I tell you what my daughter's name is? It's Abby. So she loves the name of this project. Every time somebody pushes that button, provider gets to count it towards their 5%. So we're going to use that content. And then we got payers who are working on their own content to say, okay, well, you know those stupid paper EOB forms that you get that all are basically the same content, and tables and everything else? Well, could we send that in a structured format? So they're actually working on a standard structured format so that you'll get like the ICD-9 code or the ICD-10 code, and you'll get the provider and the provider's NPI, and how much they were charged and how much they wrote down and how much is your responsibility and how much the provider was paid. You'll have all of that data, and you'll have the relationship back to the visit in an electronic form that you can automatically download from your payer using an application. So now you can start to plug that stuff back into your financial applications. Or when your kid goes to the hospital to get stitches because she wound up with this is my youngest daughter, a badminton racket came apart, and the badminton racket piece hit her right here. So she had to get stitches. So I get a bill from the hospital, right? I get a bill from the pediatric physician who actually put the stitches in, and I get a bill from somebody else. And I still don't know how much these stitches cost me. I could go figure it out now because I could go download it if I wanted to. But, you know, wouldn't it be nice if I could just pull all of that stuff in and do interesting stuff with apps and figure out, oh, well, you know, the next time when I go to the urgent care center, because that's what I told my wife she should do next time rather than go to the emergency room, I could actually compare and contrast and say, oh, yeah, you know, the urgent care center cost me $500 and these stitches cost me $1,200 to go to the hospital. So they're working on that. Push. How many people know what direct is? So we got a couple people here. So we're going to use email to send documents securely. And there's a whole protocol about how we're going to use email, and we're going to use something called SMIME, Secure MIME, to communicate information. And we're going to provide a little bit of structure using an IHE profile called XDM, or go through a gateway that uses the IHE XDR profile. And this would be transmit. We're just going to email you the stuff, Mr. Patient, Mr. Keith. And your application can pull that email apart and go do cool stuff with it. Or, more likely, or what I think is better, is to be able to pull that. And here's where we're going to be playing with fire at the Hackathon on Wednesday in January in sunny Chicago. And if you believe it's sunny in January in Chicago, you definitely need to come. We're going to be playing with fire again. So I've built a prototype for this, for the ABBY project, for the ONC S&I framework project. And it's actually using the HL7 fire specification to do this. We've got a RESTful API. There's a lot of work that needs to be done around authentication yet and dynamic client registration, but we've agreed that we're going to be using OAuth 2.0, and we're probably going to be using some of the OpenID Connect work that came out of Rex. And we've got this group talking a little bit to the IHE IT infrastructure work group about the OAuth 2.0 profiling that they're doing. So a little bit more coordination happening between the standards. And this supports the view and download. So every time a patient views or downloads using ABBY, they would qualify the provider for yet another patient doing a view or download to get to their 5%. Now, the common themes about what's going on here is that we've got connections from HL7, from IHE, from the ONC S&I framework around, well, we're going to use RESTful transport, we're going to use OAuth, we're going to be independent of content, we're going to be extensible, we're going to use FHIR, more than likely. Not all of this is agreed upon. Some of this has to be worked out. You know, I would love to be able to tell them, well, just do that. But, you know, you got to build the consensus. So this is some of the things that are coming to a standard near you or specification near you in the coming year. If you're interested in the ABBY project, go to wiki.siframework.org and take a look at that. You'll be able to, we hope, later next year, sometime in the middle of next year, you'll be able to download documents as a patient using the ABBY protocol. And earlier this week, they were actually testing the push capabilities. Next week, I'll be back here again. ONC has their annual meeting, and we'll be hearing a report out on what's happening in the ABBY project. And I thought I'd bring my daughter along so she could hear what's happening to the project, where she was actually there at the meeting for the inception. So that's going to be a lot of fun, and I'm looking forward to that. So at this point, I've probably gone on way too long and have bored you all to tears. Questions? No, you don't get it, Chris.
Yeah,
go right ahead, Chris. Go right ahead, Chris. I'm just giving you grief. Go right ahead.
So, you know, this is the third S&I panel I've sat through at this conference. And I'd like all of you to respond to the question of, so what's the hang together point for these standards? What's the minimum set for an mHealth application to have? So I'm going to put you on the spot quite a bit, I think. And I want to hear what your opinion is. Now, it's the same functional requirements we're trying to solve everywhere else to a point.
So what is the minimal functional set of standards that we need to deal with for mHealth? So go right ahead. We'll let them.
Well, is it on, not on? I don't even know where the switch is. Okay. Obvious interface, right? So I'm going to tell you the answer to that when I give my talk. I'm going to wait for his answer, and then I'll tell you.
you know, I think it's a tough question because I think you're, you know, it depends oftentimes on the implementation and what you're trying to accomplish, and I think the how standards are written and how use cases are written, and they're oftentimes based on use case implementations, and you can over-engineer something into something that becomes so heavy and so complex from a you know amount of data and amount of requirements that you'd have to carry that makes it very challenging from a very lean small device. 11073 is a very interesting example in terms of what Continua has done, and obviously Chuck's not here, but Continua helped drive out a simplified version of 11073 that had been in existence for a long time and made it much leaner and nimbler so you could put it in smaller devices. Maybe you already know this in terms of the PhD specification in terms of what goes into a device. But that took away a lot of functionality and requirements around alarming and some other functionality that's very important for hospital-based devices. So that's the point of care piece of it. So I think it depends somewhat on the application. And so I think that the standards bodies have, you know, tried to tackle that, and they've done it through, you know, at least Continua has done it through specifications. IEG has also done it through specifications and scenarios. So depending on what you're trying to do, I think dictates some of what you need. I think your question, though, is really interesting, and we'll probably hear a little bit more later. But, you know, with a lot out there, how do we get to commonality? And I really believe that's kind of the balanced approach part. You really need to have healthcare delivery really help drive that answer in terms of how they're going to implement and utilize these. And unfortunately, that's not really clear, and healthcare delivery hasn't come together with a common voice to help drive that. And we're really interested in helping engage the ecosystem on that.
So I think some of that depends on your platform. One of the interesting things is that you probably don't care about any of the standards that are already on a chip. So Zigbee, Bluetooth, USB, all of that stuff probably have no interest to you because it just works. Or at least, you know, we think it just works. Right. Well, okay. So that's one. Right. So that's, well, no, that's level 5 and below. Or actually level, you know, some of that's the wire and the connectivity. So there's that stuff. You're probably not interested in that. There's encryption, right? That's important, right? We're all freaked out about privacy and security. I think a lot more of us need to be talking to our kids. Not about privacy and security and their concerns about privacy and security, but understanding that they're not really as concerned as the rest of us are. Somebody once said, you let your daughter have a Facebook account? What happens when she goes to try to get hired? I said, you know what? That HR director will have been 16 with a Facebook account too. And will have made a mistake or 3. You know, we will learn as a society to deal with some of this internet. You know, we all have purchased stuff online with a credit card. You would never have done that in the late 90s. You just would have been open yourself up to, you know, having all your money stolen. Or at least that's what people would tell you. This will change. In terms of some of the minimum set, you know, the minimum set of standards for this is not the same as the minimum set of standards for this, is not the same as the minimum set of standards that, you know, I'm running on my laptop. It's going to be different. I do think that we're going to be seeing a lot more RESTful, a lot more plain, basic, simple HTTP, secured using things like OAuth. When this is, you know, stuff that's initiated over the web. When it's device-to-device communication, Bluetooth, Zigbee, all of the stuff that Continua is playing with for some of that. There's going to have to be bridges and gateways to deal with some of the device-to-device and then device back to the personal health record. This little device that I keep waving around now, I can't find because it's buried in my pocket somewhere, does not have my identifier in it. It's got a Bluetooth device ID somewhere embedded in it. And that's the only thing that identifies this device. And it happens to be that there's association of my identifier up at Fitbit.com with that device identifier. So I think it depends in part on platform. You know, if you look at the things that have been standardized in meaningful use, we've got most of the vocabulary there. Allergies is still a problem. If it's a non-medication allergy, we have nothing for vocabulary. Literally, we have no standard vocabulary. We could buy it. I can go buy it from 3 or 5 different vendors, but we don't have a publicly available, vetted consensus standard for allergies. That's the biggest gap in the vocabulary. In things like the RESTful APIs and what do they need to look like, where I see things going is we're going to set the world on fire. Quite honestly, I think the gentleman Graham Grieve from Australia, who basically invented this, has done an awesome job of capturing the essence of what is needed in doing some of the exchange. And it's taken some of the really cool stuff that we've learned doing CDA and said, okay, well, now let's make it so that the average implementer can do that. And, you know, I know CDA cold. I've been teaching CDA for 6 years. I've been so frustrated by how difficult it is for people to learn it. And it's not because they're stupid people. It's because it's a complicated standard. So I'm seeing those sorts of things happen. You know, what I'd love to hear back from people, and you can reach me at keith.boone@ge.com, is what you think needs to happen in standards. Because, you know, we do have an office that coordinates this nationally, but I think I'm going to change. It says on my business card, Standards Geek for GE Healthcare, but I think my real role in GE is I'm a standards coordinator. I'm actually involved in all of these different organizations, trying to figure out how to bring all of these different pieces together. And we need more of that, so I'd love to hear from you as to what you think we need in that space. More questions, or turn it over to our next speaker? Great question, Chris.
Do you have a question? Yeah, absolutely. Round of applause for Keith. And I say 7th inning stretch, so we all just kind of flex and work those muscles for a second. Great audience listening to this, being able to work through it at the same time. Sit in one place for a long time is like a bad plane flight. And I'm pleased to introduce one of the newer members of our cast of characters here. We've all worked together for a bit of time, and I now bring on board Mr. Mark Kramer. As Keith alluded, Mark is going to speak to HData, which is an initiative that MITRE has been spearheading, worked with HL7, and is now a standard rising in prominence. And I will turn it over to Mark.
Thanks, Jim.
Certainly, sir.
And certainly continue your stretch. I mean, one of the things that I've been trying to do at MITRE is get them to accept stand-up desks. So I was the first kid on the block to get a stand-up desk. And then I did something really radical, which was I put a treadmill under mine. So I'm on a walking treadmill all day, and I also have a Fitbit, and I get this baby up to 35,000 steps a day. Okay, so I walk like 10 miles a day, you know, on the treadmill, and then I'm a runner, so I go back and I run like I do like 5 miles, 6 miles. Today it's only at 3,500, which is piss poor. Excuse my French. So I feel like we all should be standing up during this talk, myself included. I might march in place. So this is kind of we've heard about standard organizations. I think all the players have been named. We've got IHE and HL7 and Continua and ONC, and we've tried to play with all these standards organizations. And really, the reason is that even though MITRE is kind of a big company with, well, medium-sized company, 6,000 to 7,000 people, really just 5 people have been involved with this HData effort from the beginning, a very low budget. And the 5 of us thought, you know, it's just a travesty that we can't get to our medical records. We can't see our health records. If I do go to my health provider, they'll say, okay, and we'll have that ready next, you know, this time next week, and you can come back and you can get a pile of paper. And it's just a travesty in the internet age that that's the case. And it's been improving. So I'm kind of rolling back the clock maybe 4 years ago when it wasn't so, even blue button didn't exist, only as a gleam in someone's eye. So, you know, with a very, very low budget and an idea of how to approach this problem, not a very deep idea at all, we basically said, hey, there's this thing called the internet, and instead of using heavyweight service-oriented architecture, why can't we just write a web page and access through HTTP and this RESTful service that we've been talking about? Why can't we just get at medical records that way? And, you know, we were naive enough, not being deep into healthcare at that time, to say, well, you know, why not? So we decided that the best route to go to achieve some change would be through the standards organization route. And I've just showed here on this slide sort of an A-B comparison. On the left is sort of the standard message-oriented or service-oriented standard where you're going to create a set of APIs, API functions, programmer interface functions, and put them out there on some sort of port that you can address. And what this means is that you're going to have a load of different functions, because every time you add a new functionality, you add the need for new interfaces. And the RESTful method is just so much simpler. It says there's only going to be 4 methods, and they're called get, put, post, and delete, and they're executed on different resources. So you heard Keith talk about FHIR, and the R in FHIR is resources, and in some way that comes from the HData view of the world as a set of resources that you can access through some simple methods. So if we add new functionality, we're really talking about adding new information resources and then getting those and manipulating those with the same HTTP methods over and over again. The other key idea, of course, from the internet is that each of those resources is represented by a unique URL. So you have an address. You point at that address and you do these methods. So that was kind of, you know, it wasn't a deep idea. I mean, the thing has been going on for many, many years, and we just decided that we would try and push that in healthcare. This is actually just another view of that same thing, and it uses a folder metaphor. It seemed to us that the C32 or the CDA had a structure which was like files and folders. And we said, well, you know, if we're ever going to have a browser-based access to this thing, we don't want this whole CDA, which, if you don't know, that's a huge, huge document if you have any history at all. And it takes a long time. It's very complicated to parse. It was just very, very difficult to receive it at the client in a browser and step through it to try and find the critical piece of information. So we scratched our head and said, well, listen, if you have an allergy, why don't you have a URL that represents your allergies and separate items for each entry in that allergy? And that actually went on to become first Green CDA and then eventually FHIR, same idea being followed through. So we really started with the standards organizations in about 2009, and again, we were kind of flummoxed by the complexity of the state of the world. And we decided to break the problem up into 3 parts. One is the organization of those resources, And, on the previous slide, I showed as kind of a file folder analogy. The second was defining these methods, and REST is only a framework, and you need a profile, a specific profile on top of that, and we wrote one, which really defined what you'd get when you do a get, and what post would mean and what put would mean, etc. And then the third part was some simplified resources, very much like what FHIR has attempted to do to break up the pieces into nice, simple XML. But what we decided after doing the first version of that was that there were other folks in the world who could do a better job. And the green CDA folks, back in the day in HL7, maybe 3 years ago, got that idea, took the ball and ran with it, and then Graham and his colleagues with FHIR have even done a better and more complete job with that. So we feel like we were, there at the origin, at least, and slightly inspirational to that. But what's happened is that that's run off in a different direction with the real healthcare experts, and I think that's a good thing. So I do want to talk about our experience of developing a standard, but I also want to talk about what it is that we're trying to standardize. So there's kind of two layers to that. As we go through, I'll kind of switch back and forth. So we have, I think, a very strong framework for interoperability, and it's comprised of 3 pieces. One piece is called a content profile, which is to be defined by standards organizations and those people who have data to exchange. And it's agreement on what kind of data will be exchanged in terms of the format of that data, the semantics of the data, and also where it's going to be located in a URL pathway relative to some route. So you'll always know that, for example, a patient's allergies will be at patient route / allergies or patient route / medications for the medications. But we don't make that as we don't include that in the standard. That's more like a plug-in that an organization can come up with. And as we've worked with different organizations, different plugins have come. And now we're working on a plugin for Continua. We've been working with the Continua organization to create plugins for data upload, for questionnaires, and for other purposes. So I'll get to that. The second is a root file, which is these are all XML files. This is an XML file which is included in a server that self-identifies what is there at the server. So if I'm a client and I hit a known URL that has some resources, I'll be able to look at that file and say, oh, they're following the medication profile from HL7, the data upload profile from Continua, and I know what that means. So that'll make it quite obvious and easy for a client to, get at the data, know where it is at well-identified URLs. And the third part of that is standard HTTP RESTful behavior. So we define what the gets and the puts and the posts are. So here's another picture of it. Basically, at the top, you've got these content profiles, which are currently being developed by organizations like HL7 and Continua and also DICOM. We've been working with them to come up with profiles, plug into the HData framework. And then these get concatenated, and then someone with data says, all right, I have this, this, and this, one or more of those content profiles, and they're exposed in a discovery-oriented file called root. And a client can come in and look at that and determine what's there, and then access those resources through simple HTTP methods. And of course, it's all under the security framework of TLS, so you're using HTTPS, so it's safe. And this is a front end to some other back end system, so that we don't really require at all that these information resources are in a HData database thing. There's no such thing. It just means that when a request comes into the server will go into the back, and whatever you're using, Epic or Cerner or whatever, it'll get that data and pull it back so that it can serve the request. And this is a two-way framework, so that the client could post new information from the ubiquitous Fitbit up into your medical record or your health record or your favorite device, your glucometer, whatever, so it can be pushed into your medical record. So as we move towards meaningful use, version part 3, then HData is able to do that, getting the patient involved with his own health care in that way. So from a client point of view, and I'll skip over this really fast, the client kind of gets a list of information. We have this idea of anything that's a list we represent as an Atom feed. It's another standard that we adopted within HData. So if you want to hit the medications directory, it'll list all the medications. It'll pull that back as an Atom feed. Then the user can parse that, look at the list. If it's a person, you'll just be looking at a list of links, and you can click on that one to see how my Lipitor prescription is and when it's due for update. And then you can get that through a specific URL, which would just be in a browser presented as a link. And the front end then would just look like something like this. And I had a colleague, Dave Hill, this week come from MITRE to present HReader. And that's a front end that's based on HData as well that just nicely formats all that information. So there's some nice pictures there and some nice secure code. And a lot of people are really interested in making sure that if I lose my device that my health data isn't compromised. And Dave's got some good solutions for Android and for iOS. So, as I said, it's kind of a twofold story of what this neophyte group tried to standardize and how we're doing and how it's moving forward. And in fact, you've heard part of the story already. Keith gave a long overview of some of the things that are going on in FHIR and with HL7 and with IHE. And that's an overlap with what I want to talk about, because a lot of those efforts, I believe, were initiated, kind of through our efforts. So this is an approximate timeline of our engagements with the various standards organizations. We started by taking it to HL7. We said, we've got this idea for this thing called HData. Would you be interested in it? And they shuffled us off to a working group, the Services Task Force, who then shuffled off part of it over to OMG, the Object Management Group, and said, that transport piece, here at HL7, we don't do that. Go over to OMG. And we got received over there. So now we're working with 2 organizations. And the participation with HL7 has continued through talking to the FHIR folks to establish or to unify the RESTful approach with FHIR, to talking with IHE and trying to align with their mobile health profile, and working with ONC with respect to REX, which Keith kindly introduced. So that's been a spin-off, and what it really is a security layer on top of HData, and we rebranded it for ONC purposes as RESTful Health Exchange. And most recently, in the last year, we've been heavily engaged with Continua, who's really pushing towards a not only taking data from devices, but also integrating that device data with a wide area network to create an internet of data for, starting right at the device level all the way up to a medical record and interactions with clinicians. So they contacted us and said, hey, we've heard of this thing called HData. Can we use that? And we said, sure, we'd like you to. So that's been a process that's been going on for almost a year. So let me drill down on a couple of these. Since it's already been introduced, I won't go into painful detail. But it was last summer there were ONC commissioned these so-called power teams to take a look at their activities and to paint a road forward or to plan a road forward. And looking at connect and direct, funny to hear it described as Bush's and Obama's idea of what what data exchange should look like. We really thought that, that really should look like maybe, I don't know, Al Gore's vision of healthcare using Al Gore's invention and not email. So we thought these were both really backward-looking specs. And fortunately, quite without our intervention, the power team came back and said, look, the industry trend is towards rest, and that architectural style is what we ought to look at. And so it's never simple at ONC, but several months later, after a lot of discussion, we were commissioned to take HData and add a security layer to it to prove in a pilot that, this could be done and you could exchange data on this thing that Al Gore invented. So that's in fact what we did. And this past year, we've run 2 pilots under the brand name of Rex. One was with Army Telemedicine. The other one is with the mHealth Information Exchange. And they focused on different problems. One was with consults and referrals. The other one was connecting small providers, healthcare providers, with HIE, and using lightweight, internet-oriented stuff to do it. So with the Army Telemedicine program, the way it's done now is that you go to the doctor says, go see a specialist. He'll write an order. That consult request goes through a payer. They approve it. You go see your specialist. And basically, that's where the ball gets dropped in a lot of cases. There's not a closed loop. And particularly for the VA, they were concerned that outside providers, they weren't getting those records back into VISTA. So, eventually we're looking at making sure that everything that happens to our warfighters, our veterans, gets into that lifetime electronic record. But this wasn't with the VA. It was a different group. But what we tried to do is reformulate this and said, well, how would this work in, let's say, the year 2000, or let alone 2012? We said, maybe it works this way, that the primary care provider will send a message, and it may be through this secure email. We decided to throw a bone to the direct program and say, we will do the secure email. But that message will have the consult request and a link. And that link will link back to the patient's medical record, which is back at the PCP, the primary care provider. And it will be something you can open up in a browser. You'll be authorized through OAuth. And OAuth 2 is a subset of OpenID Connect. We actually used OpenID Connect, which is more an edgy spec. But, OAuth 2 is in there. So we authorized through OAuth 2 to enable the consulting doctor to look at the record. Therefore, he knows the patient. He can do the proper thing on the consultation. And when the results come back, there's an email message that CCs the primary care provider, who can then open up that link and look back at the record that's produced at the consulting doc. So pretty simple. Just uses, internet technology that's been there for quite a while in a secure, medicalized way. So that was successful, and we also did another study with the main HIE, who have been really great. These guys are ahead of the game. They're leading thinkers. And we had actually done some meaningful use work with them before, and we went back to them and said, hey, what could we do with HData? And they said, well, the major hospitals are all linked in, but we have a lot of little providers, the long tail, if you will, that aren't linked in. Can you show us, if you can use web access, HData ideas to do that? And so we built an adapter for main HIE, and we built an adapter for Newport Family Practice. And they both contained this idea of the content profile. This was just with C32s. And we went back and forth, securing things with OAuth, using RESTful transport and triggers whenever the record on the Newport side was updated. And we were able to integrate them in very short order into the main HIE. So both of those projects were really rushed. We only had 3 months to do the 2 of them. They threw a lot of money at us in a very short time, and we're a very small we have a very small group really to do this, so it was, you know, a real fire drill, but that was a great proof of concept for these ideas of interoperability. As I mentioned earlier, we've been very active with Continua. Continua is currently going through a next generation standards effort. Their current standards are based on mainly service-oriented architectures, SOAP ideas, and they're very much aware that those have been difficult to sell to device manufacturers, sell in a adoption sense. They want to go to more consumer-oriented web standards in the next generation. I won't talk about their goals. They've already, you've heard Chuck talk about those. And in our discussions, the working groups, the services working group have adopted HData for their next generation profiles, which we were very gratified to hear. It'll cover things like discovering a device, the device discovering ports on the web where data can be uploaded, for data transfer, which is kind of the standard device thing to do. There's a few wrinkles because with devices, there's two-way communication. And of course, one of the things with HTTP, if you're an HTTP client, you've got to pull data. You can't be pushed data. There's certain hacks about this which attempt to hold open a connection, or it has the client constantly polling for information. But we've already heard that when you do that, your battery is going to be dead. So it has a great power draw on the device for bidirectional communication. So we were looking for some way to do that with low power. There's a lot of cooperation, actually. The question came up earlier. This questionnaire thing that Continua is working on is actually an HL7 initiative to determine what the format would be for a simple questionnaire that could appear on a device. How are you feeling today? Did you take your medication? You know, that sort of thing. And that's another part of the profile that Continua is working on. So the new wrinkle is, how do you transport and do bidirectional commands? And so what we've been moving towards is message queues for HData, which is a new thing. And you know, HTTP, I mentioned, it's very efficient, very scalable, but it's one-directional unless you hack with it. And message queues, or message-oriented middleware is a more proper name for it, is intrinsically bidirectional. It's more a peer-to-peer architecture where you have a pub-sub kind of framework. You can publish to a broker. The broker knows who's subscribing to your information. There may be one or many people subscribe, or machines subscribing to that information, so you can get one-to-one or end-to-end interactions. Also supported is different quality of service. So if you have a critical message like an alarm that needs to get to a device, or you want, you know, real positive confirmation that message got through, as opposed to just pumping data from your Fitbit, which, you know, it really doesn't matter if this update didn't come through. The next one has got my steps in it too. Another thing that is difficult when you've got a device is the idea of store and forward. So very often, if you're out running, you are out of range of a network, and when you come home, you want that device to upload. So this happens even in hospitals where you've got dead spots. So right now, application developers have to develop their own store and forward caches. And with most messaging-oriented middleware, that's done by the broker. So if you've got a broker locally, it'll store up the information, and the device can just pound that data to the broker as if it were connected. It really doesn't care. The next time the connection is made, then all that data gets bursted up to the host. So that's kind of a cool thing that really gives you some reliability. And there are many different standards for message queues, and some of them are listed there, DDS and AMQP and XMPP and MQTT, so the whole alphabet soup. And we went with MQTT in this Continua group for various reasons I won't get into. Now, the interesting thing that we came up with is a mapping between REST and PubSub. And it's not a natural match, but there is actually a kind of interesting match. And I've listed CRUD operations, which is a classical database, create, retrieve, update, delete, and compare it to REST and to PubSub. And so we were able to align PubSub, like to create something is in REST, you do a post. In PubSub, you create a topic and publish to it. That creates a new information entity. And to retrieve is basically to subscribe. So we were, not to belabor this point, but it actually makes it very, very elegant. You can use this same idea of a resource-oriented architecture with PubSub. So we're working on that right now. You won't see it in Continua literature yet because I'm going to call for 4 hours a week trying to work this stuff out. Let's skip over that. So FHIR, well, we've heard a lot about FHIR. A lot of the goals of FHIR are the same as HData. FHIR, of course, though, is kind of like a HData content profile because where HData stops and is content agnostic, FHIR is not. FHIR is very content specific. So it's it does those things we said we really couldn't do because we weren't competent enough to do them at the beginning of this project. So it's actually a very excellent follow-on to what we're doing. We're very glad to see it. And so FHIR and HData use a lot of the same ideas. We've spent a lot of time in conversation with Graham and the folks at HL7. So we're very happy to see that. If healthcare gets better and it's not called HData, we aren't going to care. If healthcare doesn't get better, then we care. So we do want some convergence so that there aren't multiple specs for RESTful interactions. We'd really like there to be, one agreement. But as people catch this idea, there's a lot of good ideas, and people tend to, say, I'm going to write my own. And so we've been working quite a bit on convergence. I'll just mention in passing DICOM. We've been talking to the DICOM folk because they would also like to have a RESTful interface to DICOM's complex tree of information that accompanies images. So I won't talk too much about that. But just as we look towards a RESTful future, and this is my get off the stage slide, we are at this point, kind of 3-4 years into the HData enterprise. We've had a real introduction to what it means to do standards. And, we really appreciate now how difficult it is and how time-consuming it is to get consensus among a large international body that meets, on a periodic basis, and things don't progress as fast as you'd like personally. And it's both a source of frustration, but as I said, when we came into this, we were like 4 or 5 guys with very little healthcare background and just really had our umbrage up about why we can't get to our healthcare data. And now, 4 years later, we've seen these large-scale trials at ONC. We've seen standards organizations adopt these ideas. Whether they originally came from HData or not, is not an argument we really want to have. They were certainly around before we proposed this. So we're just gratified that, we've been able to stir the pot in some way and move, hopefully, to the point where some years hence you will be able to see your data. It still hasn't happened, and every day I've got my boss saying, so what are the implications? List me the implementations of HData. And I'm like, well, boss, we're talking about it at IHE, and we're talking about it at HL7, and there's a whole lot of folks that are using REST out there. It's kind of a mind share game. more than anything else. So this little picture, shows our view of the world, which is very HData centric. At the bottom, there's the HData RESTful transport, which is the basic HTTP operations as defined for healthcare, with that REX security, which is actually just OAuth 2.0, or maybe OpenID Connect. That alternate transport that I've talked about, that messaging-oriented transport, which is important for devices and bidirectionality, issuing commands to devices and conserving battery life. I didn't go into all the reasons for that, but there are many. The record format, which is that hierarchical organization of information in a way that is associated with URLs uniquely, so you can always point at any bit of information. And at the top are the content profiles, which are coming from Continua and from IHE and from FHIR and from others. So I hope that's the face of mobile healthcare. It is lightweight. It can be done on devices. And it can be, it can carry information from one end to the other end. End to end means from, tiny little devices up to hospital EHR systems, and even up to super meta systems like HIEs. So as I look at the world, I try and look for that end-to-end concept, and there's a lot of complexity to it, but there's a real opportunity to make things plug and play from end to end. So that's all I have to say. I'd be happy to entertain questions.
I don't know that I have a question. It's more a comment. I remember when I first ran into Gerald, one of your colleagues, and he introduced me to the concept of HData. And I remember bringing him to various and sundry people in HL7 and watching as you folks went through the painful process that I too went through when I first got my introduction to IHE and HL7 and ASTM and Continua and all the rest, and struggling to figure out whose process and what's the process and how do I follow the process and why is this process even important? Why can't we just say it's going to be this? And I have to, just say I've been really impressed by the excellent work that you've done in persisting through all of that. And I think that if healthcare does get fixed, it will be in part because of HData.
Oh, well, thank you, Keith. And I should recognize my colleague, Gerald Bichelt, is actually on the agenda for today. I found out, much to my disappointment last week, that he was leaving MITRE and going into e-commerce, so he's systematically resigning from all those standards organizations that he so carefully courted over the years, which is a real disappointment to many of us. But we all have our goals in life. So, Jim, I'll turn it over to you.
Ladies and gentlemen, as the moderator for the panel, I'd be remiss without being concerned about your needs and wants in this session. We are scheduled to go for 2 more hours. If you would like to dwell upon any of these topics or additional topics that could be brought forward for an additional 2 hours, I, as your moderator, am here to fulfill your requests. Is there any additional areas that you may wish to consider before such time as we could perhaps complete our time together earlier than scheduled? Any additional questions, anything else that you may like to go over? One last, fantastic, one last participant.
Excuse me. Ian from Orange and also Continua. I think it's interesting that, how many people here, for example, are not standards geeks? Okay, we've got a few, but we've got a lot of standards geeks, standards people who've been through the painful process of learning standards, and I count myself and my colleagues from Qualcomm over there as people like that. So the question is, why aren't the people who aren't doing standards in here learning what standards we're doing for them and how we're going to fix the problems for them? Because, last year there was a lot of talk of standards, this year there's a lot of talk of standards, but They're
Well, you've
actually
done it.
happening.
That's 2 hours worth of discussion right there. So.
Okay. Sorry, everybody.
It's a valuable question. I mean, and it's kind of multifaceted because it's the, why isn't it the people that should be doing standards aren't here, and we get the same people who are doing standards? My concern for what it means, and I'll say this plainly as a sponsor of IHE as a standards development organization, because Keith Boone can't live forever, and he works for a publicly traded company, and regardless of his personal I'll claw in here at midnight to work on this if necessary, things arise in everyone's life that can overcome those things. We have the issue with Jerry. You have to make personal decisions for yourself, your career, and your family, regardless of where you make contributions. And there as well, so what I just referred to crudely is the hit by the bus syndrome. You step off the curb and look the wrong way. What do we do when those key contributors who you consistently see at all of these events and the faces that you recognize aren't available due to circumstances beyond your control? And how do we bring along the next generation? What is the succession planning with this sort of thinking? And perhaps worse yet, this isn't a case of doing it the same way we've always done it, so we'll find somebody who's done it before. It's what was on Keith Boone's head yesterday with regards to fire that's immediately applicable to something he's planning to talk to Mark about with regards to H data, and how would someone else fill that gap without having to literally reinvent the wheel? And what could set back a standards effort 12 months? And Mark, absolutely, Mark.
I'd like to take a crack at that. So there are successful standards and there are unsuccessful standards. And in fact, at MITRE, we once did a study, which I wish I had the results at the tip of my tongue, and I don't. What was it that made a standard successful? So I'd have to, if I was better read, I would know the answer to that scientifically. But I'm going to have to settle on an anecdotal answer. I think, what succeeds is that if it makes a particular developer's life easier, it's going to succeed. It's a standard that makes life harder is a very difficult sell. Now, it could be a business driver and a business plan that does it. So it is not all down to the developer. But if you look at Atom, you look at they're standards that have gotten around the internet. They're very lightweight, easy to implement, and I think that's something we really need to take to heart. It's very, very difficult to master CDA. So, you get a lot of complaining, but, to some extent it was the only game in town, is the only game in town. So, that's really good for people who make money off of CDA consulting and teaching and training. Those people have made very good careers being informaticists, medical informaticists. But how much more powerful would it be to use something like FHIR, which any developer, junior developer, can use and understand? So I think it's simplifying it down until it almost is painfully dumb that makes it, and putting it out on the internet, making it free is a whole heck of a lot better than having it behind some paywall. So simple and free. Sounds like I want to move to Vermont or something.
One thing I'd add, too, and mutual colleagues of ours as well that many may know, Elliot Sloan mentioned one day about, we'll have achieved interoperability when we stop talking about it. And what that really means is that at a level where those standards, and to an extent that Mark was saying this, that are transparent, freely adopted, immediately integrated, and put on like a pair of shoes, is something that helps drive what interoperability leads to, which is then, of course, successful, delivery of healthcare.
So I want to respond to a couple comments there. As the guy that wrote the book on CDA, literally, I can tell you that, I don't make a whole lot on writing books about CDA. If you're going to write a book, don't quit your day job. Absolutely right. What he said was absolutely right. My introduction to HL7 was to version 2. Somebody handed me chapters 1 and 2 and said, here's the specification for an ADT feed. And I read through chapters 1 and 2, and I looked at that and said, okay, so now I understand how an ADT feed works. And this was HL7 version 2.3.1, I think it was. So I actually had the full PDF, but I only needed to read about 40 pages of specifications. Now, it was ugly pipes and hats, basically old, EDIFACT-based standards, but I could understand enough of it that when my ADT feed broke down in San Diego in 2004 at the IHE HL7 Connectathon, I managed to, in about 6 hours, replace it with one that I wrote in Java in about that time, and was able to get the system that I was testing at Connectathon working again. These days, if you want to implement an HL7 version 3 standard, you have to go through about 3 years of V3 school. Right? You have to drink the Kool-Aid. You have to learn the RIM modeling. You've got to learn all of the stuff. And there's a lot of value in that stuff. There's a huge, huge amount of value in that stuff and why they do it that way. But what they failed to do with that I think FHIR has succeeded in doing, is actually take that content and take the intelligence that went into that content and make it simply consumable for the average engineer, software developer. And that's when standards succeed, is when we take, because frankly, there are various estimates, somewhere between 500 and 2,000 experts in healthcare IT standards internationally. Okay, this is a very small group. We can't turn everybody into experts in healthcare IT standards. What we have to do is take that expertise and put it into the standards so that the developer, the junior developer who's had, maybe 2 years of programming experience and maybe a few years in the healthcare environment, and has a degree in programming, can implement and come up with a correct implementation. And I think that's what's going to cause us to succeed, and that's why I get really excited about FHIR, because I've been teaching CDA now for something like 5 years. And like I said, the people I teach it to, they're not dumb people. They're some of the best and the brightest people, and they struggle just like I struggled with learning how to do that. So that's what I think needs to happen to succeed. In terms of what we do to bring in the next generation and how we get people here, we've seen a lot of increased attention to standards. People are starting to understand that this is valuable, that this is important, that this is something that we need to be able to build products that will change lives. And that requires marketing. Standards are volunteer organizations. How many volunteer marketers do you think show up to an HL7 meeting? If you count the number of hands raised in this room who know the answer, you've got your answer. 0. Okay? Same thing in an IHE meeting. So this requires marketing of the standards activities. This requires people to get out and actually deliver a message about why this is important and what this is going to change. That, I think, is the key change that would bring more people in.
I think there's another kind of, so I agree with what was just said, and especially about how it has to be really easy and simple and low cost, free. The other piece of it is just understanding the value proposition for the people that aren't in the room, and enabling them to really understand and want and demand. And that's not talking about standards per se, because that's, I think for a lot of the people that will really care about it, some of the conversation that we're going through in terms of the specifics and how to do it, and that's very important for the engineers and those people that are developing it, but it also needs to be appreciated in terms of what the value you can get from the connectivity and what you can do with it. I don't need to know how the code that went into how my application, my smartphone worked to give me, the current weather today or my map. But as a consumer of that, I really use it and appreciate it and know that it can help me know to put on a raincoat or, how to get from A to B. So a lot of it is not necessarily the greater I mean, we definitely need to build a community and make it easier to adopt from the implementation standpoint. But I think for interoperability to really happen, we also really need to understand the value proposition for the users of that information and make sure that they make that a priority. For example, when they're making decisions about purchasing equipment or defining, what they want, in their, 10-year plan.
Can you hear me? Yes. Okay. Module Poku from the Hopkins Applied Physics Lab. Our team does a lot of, we build a system that does disease surveillance in resource-limited countries, and we've recently been tasked to be more interoperable with other data feeds and other systems. So for us, being interoperable is important because it makes our tool much more attractive. So I guess that's a selling point that you guys could use for marketing. But my question is for our development team, which of these, I'm not a standards geek at all, so what of these standards that you've talked about today, how mature are they? And if we were to go any one direction, which one would you recommend we use as a starting point, or are they not ready for use now? And also, will they expand into the global arena too?
So I'm sorry. Can you say again what your application is, what you're trying to do?
Oh, okay. So we collect data in remote areas, and then we analyze it for disease surveillance purposes.
So you're doing disease surveillance purposes.
Yeah.
So there are a number of different standards that you can use for disease surveillance purposes. And it gets back to what is it you're trying to do? What technology do you have available? If all you have is a cell phone available for, say, doing data tracking for disease surveillance, because you're doing disease surveillance, say, in remote areas where you've got cellular but you don't have broadband, and you don't have people with smartphones, then you're going to be dealing with stuff like SMS and texting. And there are some really good examples of some things that have been done for using, say, SMS in disaster areas. There's actually a language that you can use on Twitter for tweeting about disasters that somebody's created. You could do something like that for disease surveillance. I've been working with the Alliance of Chicago using the HL7 info button standard to actually get real-time information on public health alerts. Well, it turns out that the same data that I have to send to find out if there's a relevant alert can also be used, and it's an HTTP URL, can also be used for disease surveillance. There are if you happen to be dealing with HL7 version 2 messaging, you can look at some of you could be looking at ADT messages in a hospital environment, and that can also be used for disease surveillance. But it depends very much on the context. In terms of the standards that I talked about in my presentation, HData is not yet a standard. It is something, sorry, not HData, FHIR. HData is definitely a standard. I said that totally wrong. Don't quote me on that. HData is absolutely a standard. And perfectly acceptable way to do transmission back and forth for RESTful exchange. Does that work in your context? You got to ask your technology people if that's something that you've got, because you have to look at that platform to say, well, does this standard work with this platform? Not all of these standards work on all of the platforms. My Fitbit is probably not going to be doing HTTP. It's going to be doing Bluetooth to actually a non-standard Bluetooth communication device plugged into my computer. So it depends largely on the context. Fire is not yet a standard. It is in the process of being developed. We're doing prototypes. One of the things that we're seeing that is changing quite a bit in standards, we're doing the prototypes before we declare it a standard. And this is actually a best practice that's come out of IETF work and W3C work and OASIS work. You don't get to be a standard until you've got at least one and preferably two or more implementations where people have actually tried it. The challenge in healthcare, nobody wants to implement it until it's a standard. So now you have a logjam because nobody wants to do something new because it's not a standard. Or if we go to do something new, it's never been implemented before, so we don't know if it really works. We've got to change that behavior. We've got to figure out how to be able to be more innovative. Public health surveillance, you know, if you get one data point wrong or it doesn't come across, no babies die. In some of the other activities that we're doing in healthcare, you get it wrong, babies will die. And so this is why you run into some of this very conservative behavior. And we have to figure out how to do that better and how to be able to be innovative and keep the baby safe.
You can load it up. Of course. Please do. Oh, yes, please do.
I thought you said make two. I was going to say no.
You make two guys. I think great.
First off, it's nice to meet the motorcycle guy in real life. I think it's an unfair question to ask why aren't the people who aren't here. That question needs to go to the people who aren't here. But more importantly, I think it's because right now this whole arena is in such a state of flux. It's incongruous and disparate, and so long as my little widget does what I want it to do, it's no consequences. Right. We don't start standardizing until we start rejecting things that aren't standard. And so in order for a standard to become a standard, it has to be actually used. I think that's what Keith just said. But we're not yet there because there's so many different things happening simultaneously. I was saying, I think it was yesterday, that right now it's so much stuff out there. You couldn't even print a directory of all the stuff that's out there just to be able to know, like if you say, can I get a pedometer? Just did the American Heart Health Walk, and we had like 17 different kinds of pedometers just on our team with 15 people. And, you know, and it was like, okay, what was yours say? How far did you walk? Well, you really don't know because you don't know whether it's right or not. So I think until we get to that point where we have some kind of a standard body of acceptable devices and data and something like that, it's hard to put a standard around it because it just changes so rapidly. You know what you want to get out of it, but it's just too many flavors of it right now. And so the people who aren't here, they're probably thinking, well, why should I standardize on this when I know this thing here is going to change? Right. I've done CDA, and now here comes FAR and REST and all the rest.
I'm going to take the liberty to go through Chuck Jaffe's presentation because it really leads into a lot of what we're talking about here. And it's not technical. A lot of the opinions in it are his own, but there's some that I think we all share, and I think it's kind of entertaining. And if it's loaded up, I'll go ahead and run through it. There we go. So I'll still get through this real fast. And he calls it overcoming the circle of blame. Implementation opportunities, issues, and challenges. I like pigs. Dogs look up to us, cats look down to us, but pigs treat us as equals. Just some fun quotes that he'll have through this, and I'll offer his commentary. I can't do it as well as him, but he does make some good points, I think, through it. So the players in the circle of blame is laid out here. Government agencies and regulators, standard development organizations, healthcare systems and hospitals, clinicians, technology developers and vendors, and academians. How much easier it is to be critical than it is to be correct. And here's the circle, ladies and gentlemen. All of the participants in their various points on the circle of blame. So let the games begin. First, the government says, you develop standards too slowly and too unpredictably, and so we can't necessarily use them, or moreover, we'll go over and create our own, or we'll act like a standards development organization. And then the standards development organizations come back and say, but you don't provide us the support we need. Meanwhile, the government goes back to health systems and clinicians and says, you're lagging too far behind considering the incentives we provide. Wonder what this might be referencing to. The vendors in the health systems come back and say, but your regulations are obtuse, vague, and overwhelming. The health systems go to the vendor and say, we need everything. We need it customized, and we need it yesterday. Meanwhile, the vendor comes back and says, yes, but best of breed, that's not a coherent strategy. Where does that fit into a request for procurement? Meanwhile, the nurses go to the vendor and say, workflow? You call that a workflow? And the vendor comes back and said, you put 3 surgeons in a room and you're going to get 4 different strong opinions. The pediatricians, and he specifically threw the pediatricians in here, and I don't know if you've heard this or not, but he found the pediatricians with regards to their needs for an EHR. One of the basically said, if it doesn't include head circumference, we can't consider using it as an EHR at all. Which just points out how in some medical areas you still can't have this sort of one-size-fits-all approach that you're trying to take, but you don't want perfect to be the enemy of good, as you oftentimes hear from Doug Fritzma. So the government goes back in a recent case, obviously, that we know of specifically around HL7, says charging for standards is an impediment to adoption. The SDOs come back, as well as the academics, say, okay, can we get a grant for it? And the corollary to discussion, as Chuck points out, is, you know, you're already paying to use SNOMED as a standard, so where do you draw the line and what gets paid for? And moreover, when you pay for something, what are you getting in return? Is the intellectual property associated with standards that are used worth paying for? And what about the reimbursement associated with the time and effort and resources that go into the participants and same volunteers in getting those standards developed, validated, and then assist with implementation? And then the hospitals and vendors and academicians come back and say, do we really need a license? What happened to open source? Well, open source doesn't necessarily imply free. And then the academics come back and say, again, standards are an impediment to innovation. And then the clinicians say, well, what's a standard? And then the hospitals and vendors go back to government and say, can this whole thing just be postponed until 2020? Meanwhile, the government rushes back to the standards folks who are saying that things were being impeded and say, can we just accelerate this to the first quarter? And now, of course, the hospitals and clinicians report back to the government as they get concerned about these incentives and say, well, you know, in fraud and abuse, if you're not cheating, you're not really trying. Which is really just an offhand reference if anyone has seen those comments lately about how EHR systems may be assisting in helping the fraud, waste, and abuse, which really doesn't necessarily come down to... Oh, by the way.
That report is based on data that came out before the program.
Correct. Absolutely. Before there was the level of implementation for EHR as it exists now. 2 years before that, as a matter of fact.
And of course, we used the reason
That's right. So what Chuck makes the point of saying is, if you're not guilty of any of these elements of the blame game, then you shouldn't be in the room in the first place. Knowledge is knowing that a tomato is fruit, and wisdom is not putting tomatoes in a fruit salad. Some other principles of the blame game. In the blame game, no one wins. But everyone is trying to win based on their perspective, of course. You know, to be sure of hitting the target, shoot first and call whatever you hit the target, which is, of course, an approach from standards perspective. Ignorance is never bliss, and intentional ignorance is even worse. All you need in life is ignorance and confidence, and then success is sure, as Mark Twain says. Policy trumps technology. something that I think in many cases we struggle with because the technology comes first, and then we deal with the policy implications afterwards. It's okay to give someone else credit because, after all, the people who are important will really remember who did this for you. And that's also another reference to just how credit is necessarily given in those cases, particularly in academic environments. Well, you know, and Chuck talks about this much better from his medical experience in terms of saying if you didn't have your name on a research paper, or you aren't doing research papers, or you aren't constantly trying to pursue research grants, you're just not going to be noticed at all, regardless of your other achievements. So the world is divided into two people, divided into people who do things and people who take credit. Try if you can to belong to the first class. There's a lot less competition. And there is a solution to the blame game, which probably speaks to the people that aren't in this room now. Accept responsibility that you in some form or facet are part of the problem. Make compromises. Tolerate others' shortcomings and appreciate that you have some too. Celebrate the victories, even the small ones, which I think we try and do within some of the standards development work, and set those as the basis for building to a larger victory and moving on to something else. Keep the promises you make. Be trustworthy. And a closing thought. The difference between physicians and pilots is that pilots realize they have to get into the airplane with the people that they care for. And the last one he always likes to throw up. Cough just for old times. So that truly concludes all that we have to offer today. Thank you very much for your participation, your active participation despite the crowd. I hope you enjoy the rest of the day here and have a safe drive home.